cleaning up my glasses. Let me try and share this. How do I do this? Welcome, welcome. How are you doing? I was trying to share the live. Remember to go ahead and share up the live, please. All right. And thank you. Curlan 7. Oh, that's smalls. Is it small? Yeah, it looks like smalls photo. Kiki Braids, welcome. Thank you for sharing up the live. How are you guys doing? All right. Yes. Because I saw the name and I'm like, that looked like Smalls. Smalls photo, but then the name was a little bit different. Okay, nice. Yeah. Tasha, welcome. Thank you for liking up the live. Yeah, my eyes are blurry. I don't know if they're just, sleepy. I want to close down. I don't know, but I tell you, yeah, I'm gonna see. All right, good. All right, a little clearer. Delano Brown, welcome, welcome. Renorta, welcome. All right, so we're gonna thank you for the heart me. Remember to go ahead and share up the live, and remember to go ahead and do all of the wonderful things you're supposed to do with the heart me's. You understand? As me say, I'm still learning about the heart me's. I normally give it out, but I don't really know what I'm doing. So I learned the other day that there are things you need to do. So definitely go ahead and share up the live, comment, do your daily heart me's. And I think there is something else, but you guys will figure it out as well. All right, so we're gonna do our questions tonight again. Hope I'm loud enough. Welcome on YT. If you know anybody on YouTube, I'm streaming on YouTube as well at the same handle, ThinkNursing. So they can also join from there. Yeah, remember to tap up the screen. Work those fingers, all right? Don't let arthritis take over your thumb. All right, so we'll do that. So I prepare a few questions. They're considered to be hard type questions for the NCLEX here. So we'll go through as usual. If you know the answer, choose A, B, C, D. And you just write it in the comment section. If you don't know, you have to find one, because remember, the patient is in front of you and the patient needs your help. So you're the nurse, so definitely choose an answer to save that patient's life. All right. So that's it. Oh, I said I wanted to read a little bit of a thing here. Hi, Sharwan, welcome. I wanted to read a little thing here regarding the different drugs that can cause toxicity to the kidneys, the liver, and the ear, because these are a lot of questions we notice that have been coming that does talk about toxicity. So the drugs for nephrotoxicity, which is a kidney, you have your high dose acetaminophen, acyclovir, aminoglycosides, your ciprofloxacin, methotrexate, your NSAIDs, rifampin, sulfamides, tetraglycine, and vancomycin. And most of the time, you're talking about the parenteral route for those medications. And then for the hepatotoxicity, which is the liver toxicity, you're talking about your ACE inhibitors, acetaminophen, alcohol, iron overdose, estrogen, fluconazole or diflucan, your isoniazid, ketoconazole, NSAIDs, phenytoin, rifampin, just to name a few, and the sulfamides. And then the ones that cause toxicity for the ear, ototoxicity, is aminoglycosides, butanamide, cisplatin, erythromycin, furosemide, hydrochloroquine, NSAIDs, salicylates, and vancomycin. And these are just a few. And if you realize, most of them does have your aminoglycosides, your vancomycin, and sulfonamide. So what I would encourage persons to do is look at all three different, the class of toxicity, whether nephrotoxicity, ototoxicity, or the hepatotoxicity, and look at the ones that are most common right across the board. Most of the time you realize that the answer is the same. They'll always bring back either the vancomycin, the aminoglycosides as one of the answers for the exam. All right. So you just have to figure out the easier way out. So sit down and look at the different drugs and compare them and see which one is most common for all three of them. And from there, you can try to remember that one. All right. All right. So I think that was the three I wanted to look at. Okay. Yeah. And then, the food-to-food drug interactions. You talk about your drugs such as your antacid, so your calcium carbonate, your Tums used as a calcium supplement. So you also have your antibiotics, which is your erythromycin and your penicillin. All right, so you want to avoid anything that has citrus foods, colas, and any food for your antibiotics. Tetracycline. You talk about your calcium, all right? So you want to avoid food, calcium when you're taking your tetracycline. Anticoagulants such as your warfarin, you want to avoid anything that has vitamin K, all right? So your green leafy vegetables. And for your antacid, we talk about your bran and whole grain breads, all right? For your food-to-food drug interactions. All right, so let's start with some questions. And thank you for the follow. All right. So the first question is, a nurse is caring for 4 clients. Which client should the nurse assess first? Is it A, the client with COPD on 3 liters of oxygen who reports dyspnea on exertion? B, a client with type 1 diabetes who has a blood glucose of 55 milligrams per deciliters and is drowsy? A client with heart failure who has 3+ pitting edema in the legs, or a client with post-cystectomy with a 7 out of 10 abdominal pain? So you have these 4 patients. Which client should the nurse assess? So is it the one that has COPD on 3 liters of oxygen who reports a shortness of breath and with exertion? A client with type 1 diabetes who has blood glucose of 55 and is drowsy? A client with heart failure who has 3+ pitting edema in the legs, or a client who has post-cholecystectomy with abdominal pain of 7 out of 10? Renorta says B. Carousel says B. Okay, so that's a client with type 1 diabetes who has blood glucose of 55 milligrams. Definitely. This question looks like one that we had the other day. All right, so because the patient is, the glucose is 55, the patient is hypoglycemic, all right? That person can go in a coma, definitely. And the patient is also drowsy. So you want to go ahead and make sure you address that patient because it can progress to coma. Dyspnea with exertion is expected when you have a patient with COPD, and edema in heart failure is also chronic, all right? Pain after surgery is gonna be present, but it's not life-threatening where you have to run to that patient first. So always go ahead, and as we say, always look at the questions and answer using your airway, breathing, circulation. That's what you're gonna use to guide your choosing your answer, as well as assessment. All right. What are two medications, or name two medications that you could actually use for the treatment of diabetes? Do you know two medications that you can use in the treatment of diabetes? You could be a good teacher. I'm so grateful for your knowledge. Not a problem. Thank you so much, Renorta. Okay. All right. So what are two medications you use for diabetes? You can type them in the comment box below. This is not an ABCD question. All right. So what are two medications, two common medications that is used for the management of diabetes? All right. So you have your insulin and your metformin. Yes. What about heart failure? Metformin, good. What about heart failure? Just give me two medications that you think about that we use commonly for heart failure. ACE inhibitors, okay. Do we have another one? ARBs, okay. And what about the common one, the most common one? When you think about, you know, your heart failure patients, your fluids, your loop diuretics, your furosemide, definitely. All right. A client is prescribed digoxin and has the following lab values or data. Heart rate of 58 beats per minute, potassium 3.0, digoxin 2.5. What should this nurse do first? Is it 1, hold the medication and notify the provider? 2, administer digoxin as prescribed? 3, give potassium-rich foods and administer the dose? Or D, document findings and recheck in 4 hours? So you have a patient that is prescribed digoxin and has the following data. Heart rate of 58 beats per minute, potassium of 3.0, digoxin 2.5. What should the nurse do? Hold the medication and notify the provider. Administer digoxin as prescribed. Give potassium-rich foods and administer the dose, or document findings and recheck in 4 hours. Jacqueline says A, hold the medication and notify the provider. Do we have anybody else with another answer option? Remember, you're the nurse at the bedside with this patient, so you have to do something, all right? All right, Renorta says A. All right, why you say A? Why you want to hold the medication and notify the provider? 58 is not a bad heart rate, so why you want to hold it? Hypokalemia, because the patient have reaction and you get in contact with the, because the patient have a reaction and you get in contact with the doctor before. Okay. All right, so see your answer, first time here. Okay. Well, thank you so much for tuning in. I am blessed. All right, so yes, the heart rate 58 is low. All right, it's low. The potassium there is 3, which is also low, but you have to remember that, you know, the client is gonna be at risk here for toxicity. So you wanna make sure you're not gonna give this patient the medication and then cause, you know, bradycardia, hypokalemia and all. So definitely you wanna withhold the medication and then withhold the medication, and then from there, you know, get in contact with the doctor to find out what next they want to do. All right, so hold the medication and notify the provider. The digoxin level is also elevated, so you definitely want to make sure you know, not give the medication and then, as I say, cause further problems with that. All right. And what's the normal range for your potassium? What's the normal levels for potassium? I know you're gonna have like different range, but what's the what is it that you're taught in, you know, nursing school, the standard? 3.5 to 5. Good. All right. And yes, a normal heart rate for adults is, what's the range for adults heart rate? 60 to 100. And what's for children, your pediatric? Well, let's say newborns. What's the range you're looking at for heart rates for newborns? Anything over 140? Okay. Anything, yes, 120/60. Good. All right. So the client is assigned. So a client is assigned to a private room. Which of these patients would you assign? All right. Is it the client with shingles or herpes zoster with open lesions? Is it the client with pneumonia on IV antibiotics? A client with neutropenia post chemotherapy? A client with uncontrolled diabetes? So you have one private room and you have these 4 patients. Which of these patients would you take and put in your last room? All right. Is it the client with shingles or herpes zoster with open lesions? Is it a client with pneumonia on IV antibiotics, which is B? A client with neutropenia post chemotherapy, which is C? Or D, a client with uncontrolled diabetes? So Carol Cell says 3, which is a client with neutropenia post chemotherapy. Okay. Do we have anybody else? Hi, Jesse. Thank you so much for tuning in and for your comments there. All right. Remember to go ahead and tap up the live as well in the meantime. Do we have anybody else with another answer? So you have one private room. Who would you put in that last room? Is it the client who has herpes zoster or shingles that has open lesions? The client with pneumonia on IV antibiotics? A client with neutropenia post chemotherapy? Or a client with uncontrolled diabetes? So we have one person who says that they'll put the neutropenic patient post chemotherapy. I just want one more answer. Let me see what the answers are. Remember, you're at the bedside or you're the nurse and you definitely need to put your patients in a room. So who are you going to be putting in that room? So Renorta says, yes, chemotherapy patient, and I did not know if I already found out that the person do chemo. All right, remember, try not to read into the questions. All right, whatever is presented on the exam is what you're working with. Can make people say yes. All right, so the answer though is gonna be the client with the shingles. Just because it says open lesions, that is gonna be an airborne patient. So you definitely want to put your shingles patient in a, in a room. All right. The client with pneumonia can stay on the regular floor. The client with neutropenia post-chemotherapy, yes, you definitely want to put them in a private room, but you also can, make sure they're wearing their masks. So even if they're in the hallway, just make sure they're wearing their mask. You're wearing your mask just to protect the patient. All right. The client with uncontrolled diabetes can also go anywhere. But the patient with the shingles, you want to definitely get into a room because of the risk for, infection, or with the fact that the lesions are open. If the lesions are closed, then you can always run the risk and say, okay, you can keep them close by. Yes, shingles definitely. All right. So the client with the shingles or the herpes zoster is the one you're going to be putting in that private room. All right. So shingles with open lesions. I remember to always just look at the words that they're using. All right. Shingles with open lesions required airborne and contact precautions. Pneumonia requires droplet but can share a room. Neutropenic needs protective isolation, and diabetes does not require isolation. All right. So the mere fact that the lesions are open, you want to go ahead and put on all of your proper gears and get that patient in a private room. All right. All right. So which task is most appropriate to delegate to an experienced, unlicensed assisted personnel, the UAP? Is it A, teaching a client how to use an incentive spirometer? 2, assisting a stable client with ambulation after surgery, hip surgery. 3, assessing a client's pain level after analgesic administration. D, evaluating a client's understanding of discharge instructions. All right, so Renorta says B, which is assisting a client with ambulation after hip surgery. Carousel says B as well. All right, good. So definitely, so remember, it's the UAP, the unlicensed assisted personnel. So those persons can help with, assisting a stable client with ambulation after surgery. Anything that has to do with teaching, evaluating, assessment has to be the primary responsibility, or if it is a primary, the first time it's going to be done, it has to be done by the registered nurse. All right. So for this question, you have to know the scope. You have to know your scope of practice, or just know the roles and responsibility for your support staff. All right, in order to answer this question. So UAPs can perform tasks that are routine, non-invasive, and stable. Teaching, assessing, and evaluating requires the registered nursing judgment. All right. So always remember that. So whenever you have any patients and you're going to be saying, oh, nurse, go over that side and check if the patient is still having chest pain, even though you're just using the simple word, go and check for, if the patient is having chest pain or whatever it is, that is your primary responsibility. All right. So always remember that. A client with 32 weeks is 32 weeks pregnant, presents with severe preeclampsia, which finding requires immediate intervention. So you have a patient who is pregnant, 32 weeks gestation, and the patient has severe preeclampsia, which finding requires immediate intervention. Or before that, what are the criteria for determining that a patient has preeclampsia? What is it that you're looking for? So every time you hear patients be going into the hospital, we take this routine urine, and sometimes patients can be annoyed with it. What is it exactly that we're looking for? Why are we doing the urine test for these patients that are pregnant? So what are the different things we're looking for? We're looking for proteinuria, sugar in the blood. Okay. All right. Do we have anything else that we're using as a criteria for guiding or determining whether or not a patient has preeclampsia or preeclampsia? So you look at protein. What else? You're looking at the swelling. You look the legs that are swollen. You're looking at the blood pressure, things like that. All right. So a client at 32 weeks present with severe preeclampsia, which finding requires immediate intervention. A, blood pressure of 168 over 110. 2, 3 plus proteinuria. 3, epigastric pain and nausea. 4, 3 plus deep tendon reflexes. So you have this patient with severe preeclampsia, which finding requires immediate intervention. Is it the blood pressure of 168 over 110, 3 plus proteinuria, 3 or C, which is epigastric pain and nausea, or 4, 3 plus deep tendon reflexes? Carousel says A, which is the blood pressure of 168 over 110. All right. Do we have anybody else with another answer? Watchman says A. Okay. All right. So both persons says A, which is the blood pressure of 168 over 110. The answer is actually the epigastric pain and the nausea. All right. So epigastric pain involves or indicates liver involvement and is a warning sign of imminent eclampsia or HELP syndrome. All right. This is an emergency. You have high blood pressure, proteinuria, and hyperreflexia, which are concerning, but not as immediate, life-threatening. So I guess we need to read a little bit more on preeclampsia, eclampsia to find out what are, things that are considered to be life-threatening for those patients. So as I said, normally you look at the blood pressure, you look at the, the edema in the lower extremities, as well as the protein in the urine. But one thing that you definitely need to find out from these patients if they're having epigastric pain and nausea. But then again, with the nausea, sometimes you're probably wondering, because you have the patients, they're pregnant and they're having nausea. How are you going to be able to determine? I guess you have to look at the fact that if the patient has all the other symptoms or the other signs, they have the protein in the urine, they also have the elevated blood pressure, the swelling in the ankles, and then they're gonna have, the nausea and the pain. Then you'll be able to say, okay, then this is the direction that we're going. All right. And then from there. So once they have the epigastric pain and the nausea, along with all the other things, you're thinking about liver involvement, which is a warning sign of eclampsia. And with eclampsia, we talk about one thing that is, consistent with a patient with eclampsia. What is it that makes it different from preeclampsia? What is it? When a patient has eclampsia, what changes? What is it that changes in their status? So they have everything else. Yes, so the seizure diagnosis or active seizures at that time change them from preeclampsia to eclampsia. All right. A client with schizophrenia is pacing and muttering. The voices are telling me to hurt myself. What is the nurse's priority action? So you have a client with schizophrenia that is pacing and muttering that the voices are telling me to hurt someone. What is the nurse's priority action? A, ask the client what the voices are saying. B, place the client in seclusion. 3, notify security immediately. D, assess the client's plan and take the necessary steps to ensure safety. So you have a client with schizophrenia that is pacing and muttering. The voices are telling me to hurt someone. What is the nurse's priority? A, ask the client what the voices are saying. B, place the client in seclusion. 3, notify security immediately. 4, assess the client's plan and take steps to ensure safety. What is it that you're going to be doing at that time? All right, so you're with this patient. What is it that you're going to be doing? All right, so DD, which is assess the client's plan and take steps to ensure. Yes, you always want to ask, questions. Ask the right questions. So the patient is having thoughts of, homicidal ideation, suicidal ideations. Always find out what their plans are. All right, so you always want to find out what, intentions they have. Are they planning on acting on it? And then from there. So safety is always priority. The nurse must first assess the risk to harm to self or others, and then you think about seclusion or security, which is necessary, but after you've done your thorough assessment. All right. Ask the client what the voices are saying. The patient already tell you what the voices are saying, so you don't need to go ahead. You need to just find out, do they have a plan to hurt anyone or themselves, or what the plan is. All right. Placing the client in seclusion, and we know that when it comes on to seclusion and restraints are always, physical restraints are always last resort. All right, you want to always try other things, and then you can think about your physical restraints after. All right, a client with chronic kidney disease as lab results, so potassium is 6.8. The BUN is 88, creatinine is 5.2. Which action is priority? Place the client on a cardiac monitor, restricting fluids, administer sodium polycistrine sulfonate or Kayexalate, or prepare the client for dialysis. So you have a patient who has chronic kidney disease and has the following lab results: potassium 6.8, BUN 88, and creatinine 5.2. What is your what is it that you're going to be doing as priority for this patient? Are you going to place the patient on a cardiac monitor, restricting fluids, administer Kayexalate, or prepare the client for dialysis? A, B, C, or D? And thank you so much for joining in. Remember to go ahead and follow or subscribe. All right, and tap up the screen as well. All right, to give the video a thumbs up. We're just discussing nursing questions here. So feel free to go ahead and put your answer, your option down below. All right. So D, prepare the client for dialysis. Carousel. Okay. Do we have any other answer? All right. So you have this patient who has chronic kidney disease and the potassium is 6.8. You are going to prep this patient for dialysis. It's going to take you a few hours. But remember, you have the patient there with the potassium that is still high. And we know that that is lethal, right? Because what is it that you're thinking about with the potassium here being so high? You're thinking about your arrhythmias with the potassium being so high. So preparing the client for dialysis, yes, that's going to be a part of your plan. But for, your priority right now, what is it that you can do in the meantime? Because you're thinking about the risk for arrhythmia. So one thing you want to do is make sure you put your patient on the cardiac monitor, things like those. All right, so you want to identify whether or not this patient has any lethal rhythm going on. All right, so the first thing you want to do here, the priority action is going to be to place the patient on the cardiac monitor. All right, because the potassium is 6.8, which is severe hyperkalemia. This can cause lethal arrhythmias, so cardiac monitoring is important and immediate. Dialysis and medications will help long term, but the nurse must first prevent sudden cardiac arrest. So always be thinking about what can happen at this moment. All of these other things, yes, they're important, but it's going to take a while for you to get those things going. So in the meantime, what can you do as priority? You know, get the patient on the monitor, get an EKG, things like that. Make sure you have your IVs in place. In the event that this patient starts developing some lethal rhythm, you're able to identify it and start treatment. All right. Okay. So the nurse is teaching parents of a toddler about safety. Which statement shows need for further teaching? So you have the nurse that is teaching parents of a toddler about safety. Which statement shows the need for further teaching? We will keep cleaning supplies in a locked. Oh, we will keep cleaning supplies in a locked cabinet. B, we will give our children a small toy when eating to keep them busy. 3, we will place car seat rear facing until at least age 2 rather. We will need to install safety gates at the top and bottom of stairs. So which statement shows the need for further teaching? B, which is we will give our child a small toy when eating to keep them busy. What are we thinking about here? You have somebody that is a toddler, you're going to give them a small toy. What are you thinking about? So B, yes. So if you give them a small toy, yes, they're at high risk for choking hazard. Yes, so you want to try and eliminate that. All right, all the other answers are correct. Keeping cleaning supplies in a locked cabinet is good. Placing the car seat rear facing until at least age 2. Yes. We will install safety gates at the top and bottom of stairs. All of those are good. But the one that says, you know, the small toy, they're at so much high risk for choking. So you want to try and avoid that. All right. A nurse finds a client collapsed in the hallway. The client is pulseless and not breathing. What is the nurse's first action? You're good, Holy File. All right. So you're walking in the hallway. This is not a patient of yours. You realize that there's a patient on the floor that is pulseless and not breathing. What is going to be your first action? A, begin chest compressions. 2, call for help and activate emergency response system. 3, provide 2 rescue breaths. 4, check for medical alert jewelry. All right, so you have a patient, you're walking in the hallway or you're on the road and you see this patient is pulseless and the patient is not breathing. What is going to be your first action? Is it begin chest compressions, A, B, call for help and activate the emergency response system, 3, provide 2 rescue breaths, or 4, check for medical alert jewelry? So Renorta says D, check for medical alert jewelry. Okay. Which other, do we have another person with another answer? So begin chest compressions, call for help and activate, you know, the emergency response system. Provide 2 rescue breaths and check for medical alert jewelry. Holy File says B, call for help and activate emergency response system. Always remember to use your BLS guidelines when you're answering these questions, so you can know if they have high blood pressure or other medical conditions or diabetes. Yeah, you definitely want to know that, but remember, you know, this patient is dying, so you're going to want to try to get all the necessary help, and then from there, if they have high blood pressure or anything, you're not going, well, you definitely want to know their history, but during this time, you know, the history not that important, all right? The history is not that important. What is important is making sure that you're getting blood, oxygen to the heart and the brain. So you want to start as quick as possible to, you know, doing different things. So you activate your response team, and then you can go ahead and start doing your resuscitation. All right. But checking for medical alert jewelry. that's not a part of the BLS guidelines. So just use the BLS guidelines to try and answer the question, because when you check it, you're there checking to see whether or not this patient is diabetic, hypertensive. You find out what is happening. That patient is there dying. You understand? So definitely do that first. All right, so call for help and activate the emergency response system is the correct answer. According to BLS, the first action is to call for help, activate the code, then begin high quality chest compressions. All right, and we're talking about your CAB. We're going to use the CAB, circulation, airway breathing. You want to make sure you start getting blood around in the heart of this patient or in the body of this patient, get blood to the, or oxygen to the brain. All right. Yes, so definitely do that. All right, so that is the order of how you're gonna go about with doing that. How many persons will go ahead and provide those 2 rescue breaths? Thank you so much for tuning in. How many persons gonna go ahead and do those 2 rescue breaths? So for that one, no, when you're doing the 2 rescue breaths, probably, well, but yeah. All right, you're gonna go ahead and do your high, your high quality chest compressions for these patients. All right, you pump, 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 and that's the most important thing. All right. All right. But again, some people don't want to be resuscitated, so I could get confused with that. As I said, during those, situations, you're passing by a patient, you're not thinking about that. It's not like the patient is in the hospital. It's not like the patient is in the hospital. So for example, you're passing by, you don't know whether a patient is in the hospital, and you know that, okay, then, definitely you want to go over and help that patient. We're not going to sit down and be digging through this patient's bag and then be like, you always want to go ahead and still call for help. And then from there, as I said, try not to be, they are unconscious, you can do it. Try not to read too much into the question. Try not to read too much in the question. If they are already admitted patients in the hospital, most of the time we already know their code status. You understand? But if you're passing by somewhere, the first instinct or whatever you're going to be doing is to go ahead and call for help, try to get that patient resuscitated. In the event that, after trying to get, blood flow to the heart, oxygen to the brain to preserve those vital organs, if in the event that you do come across, their directives, then definitely you go ahead and, that's going to be a decision for the provider or for the team to make sure that they, accept the patient's wishes in terms of if they're on do not resuscitate or something like that. All right, but for the first, as I say, for the first instinct or the first thing you're going to do, you're going to assess, but at the same time, go ahead and call for help, get additional persons there and do what you're taught in the BLS course, all right, as a part of the guideline. Hi, Abby, welcome, welcome, welcome. All right, and then from there. So the charge nurse is delegating task. Which task is appropriate for the LPN or the LVN? Is it initiating blood transfusion? A. 2. Monitoring for side effects of IV antibiotics. 3. Developing a discharge plan. 4. Performing the initial assessment on a patient. And that's the admission assessment. So you have the charge nurse that is delegating task. Which task is appropriate for your LPN, your LVN? Initiating blood transfusion. 2. Monitoring for side effects of IV antibiotic. 3. Developing a discharge plan or performing the initial admission on a patient. And we have Abby saying monitoring for side effects for IV antibiotics. Carousel says the same, which is B, which is correct. LPNs can monitor stable patients and report changes to the nurses. They cannot initiate blood transfusion, perform initial assessments, or plan care. All right, so always remember that. That's going to be your duty. All right, so if you have 10 patients coming on the floor and you and the LVN is assigned there, all of those patients are yours. Well, we don't know that all of them are your own, but in terms of doing the admission, it's going to be your responsibility. All right, so make sure you do that. When it comes on to blood transfusion, what was I going to say again? How do you go about with monitoring a patient that has blood transfusion going? How, like in terms of, so for example, you get the order and you do your checks and everything. How often do you monitor these patients? What is the guideline when you have a patient that is getting blood transfusion? Thank you so much, guys, for tuning in. Remember to go ahead and tap up the live. First 15 minutes by the RN, definitely. You stay beside the patient and you monitor. Forever blessed. Welcome, welcome, welcome. Thank you. Thank you. So definitely for the first 15 minutes, you go ahead and you know, monitor, stay beside the patient and get that blood transfusion going. You're monitoring for what? So why are you staying beside the patient for the first 15 minutes? Why you don't just hang the blood and just walk out of the room? Why we don't do that? We're looking for any side effects, you know, reaction during those first 15 minutes. All right. So for example, you know, you give the patient sudden side effect. Yes. So for example, you're giving the blood and you realize that this patient start complaining that they're having the itching. You know, they start saying that they're feeling short of breath. They feel something in the throat and you're not so sure what it is, and the patient is saying, I just don't know what it is, nurse, but I just don't feel well. And you look on the monitor and the heart rate is now like 105. The heart rate was hanging out at 70. The patient is nauseous. What are you going to be doing at that time? Remember, you have the patient is getting the blood transfusion. You're going to stop the blood, and what you're going to be doing at that time? So you stop the blood, you just turn off the blood, and you still just have the bag there with the blood. And the patient is still saying, nurse, I'm just not feeling well, you know, I'm just not feeling well. And you're there panicking and you're like, okay, then what am I going to be doing? What is it that you're going to be doing for this patient? So we're thinking that the patient is having a reaction to the blood. So you're going to stop the blood, disconnect the blood, try to get, yes, administer whatever there is. Forever Blessed says, yes, you're going to go ahead and try to get some medication for this patient. So if you're going to get some antihistamine, if you're going to get some nausea medication, something to help with, you know, the patient's nausea, the vomiting, if they're having the itching, you want to go ahead and do that. If it means that, you know, most of the time you're going to have 2 IVs. Always make sure you have 2 IVs when you have your patients that are getting blood transfusion. Because the last thing you want to do is, if you have a patient that is getting blood transfusion, the tube or the IV itself is already with that blood. The patient is getting a reaction. You know, you don't want to go ahead and then just flush in the remainder of that blood in the IV. All right. If you have one IV that you're working with and you're trying to save it because you don't have any other one, then definitely you can always pull back, try to get back some of that blood out of the IV itself and then flush. But always make sure you have 2 lines when you're starting your patients on blood transfusion in the event like this, situations like this happens as well. All right. So we're doing NCLEX questions. We're just talking about blood transfusion. So you discontinue the medication or the blood itself. You always go ahead and give your medications and you continue monitoring your patient. And always make sure that blood goes back to blood bank so we can do the necessary checks on it. All right. So we said that. Okay. All right. So which nurse? No, we're not going to do that. So the nurse has 4 clients. Which task is best delegated to the LPN? Administering morphine IV push for severe pain, giving oral antibiotics to a stable client, teaching a client about new insulin administration, or assessing a newly admitted client with chest pain. So you have 4 clients. Which one can you delegate to the LPN? B, giving oral antibiotics to a stable client. Definitely. Because administering morphine IV, that is going to be the RN. Teaching a client about a new insulin administration is going to be the role of the nurse. And assessing a newly admitted client is also going to be the primary responsibility for the nurse. All right, so the one that says give oral antibiotics to a stable client, and you have to always look at the words that they use. Stable. Most of the time you will see the word stable in the answer. All right, so that's the giveaway. All right, so LPNs can give oral medications to stable clients. IV push narcotics, teaching and admission assessments are RN only task. So always, you know, be mindful of those and delegate appropriately. All right. A client, so which client can be delegated to the LPN? Is it a newly admitted client with suspected sepsis? 2, a client receiving blood transfusion? 3, a client with stable hypertension requiring scheduled medications? 4, a client who just returned from surgery with chest tubes. So which patient can you delegate to the LPN? So Abby says 3, a client with stable hypertension requiring scheduled medications. Definitely Renort and Carousel. So C is the answer. A newly admitted client, as we say, anything that has the word new, new admission, definitely is gonna be, for the nurse. A client receiving blood transfusion is gonna be the primary responsibility for the nurse. Client who just returned from surgery with chest tube for the nurse, because you want to make sure that you're assessing, checking to see if you have, excessive, like, bubbling in the tubing. All of those things, when you're checking for your post-op patients who are on chest tube, you want to go ahead and do that. All right, so that is going to be yours. But the client with stable hypertension that requires scheduled medication is going to be someone you can delegate to your LPNs. All right. And when you have a patient with chest tube, what are some things that you're looking for with that patient? So you have a patient that comes out of surgery with chest tube. What are some of the things you're looking for? Bleeding, internal bleeding, okay. How would you know that this patient is having internal bleeding? Okay, you're looking at the respiratory status if the blood comes up through the tube. But the tube, yeah, you definitely, yes, the blood is gonna be there. That's the purpose of the chest tube, to drain, drain the excess blood or the fluid, the secretions from there. But I thought you were thinking about like in the abdomen itself when you talk about internal bleeding. So I was just wondering, sorry. All right, so definitely look at the respiratory status, checking the abdomen if it's distended, yes. Okay, and then with the tube, with the chest tube, what are we looking for? What if you see a lot of bubbling sensation in it? Are you concerned about excessive amount of bubbling in the tube? Are you concerned about the amount of drainage, coming from the tube? Things like that you're gonna have to look at. You understand? So definitely, because you don't want it to be a case where you just have the chest tube just the fluid or the output is like increasing over the next 15 minutes, 1 hour. You want to make sure that you have a set amount of fluid or blood that is being drained each hour. So that way you can identify whether or not this patient is having a hemorrhage. All right. You also want to look at the bubbling to make sure that there is no ear leak or anything. You also want to look at the neck, make sure there's no tension pneumothorax, developing. So that patient is going to be a very critical patient. It's going to need an RN to, make sure they're doing the evaluation, check in to make sure nothing is going to be there that is complicating this patient's status. All right. So always look at those things. All right. Which task should the RN delegate to the UAP when preparing a client for surgery? So you have a patient that is going to surgery. What task can you delegate to the UAP, which is the unlicensed assisted personnel? A, obtaining baseline vital signs. 2, ensuring consent form is signed. 3, teaching the client about post-op exercises. Or 4, assessing for allergies. So you have a patient that is going to the OR and you want to delegate some duties because you have 5 patients that you're prepping. Which one is a task that you're able to delegate? So we say A, obtaining baseline vital signs. Definitely. Ensuring the consent form is signed is going to be the primary responsibility for the nurse, teaching as well, and assessing for allergies. All right. When the NG tube is messy, is that okay? When the NG tube is messy, I don't like messy NG tube, honestly. I don't like messy NG tube. So we always, doing the different checks with your, to make sure it's placed properly. And if you're a good nurse, you check its place properly. You can always go ahead and remove the taping. You can always go ahead and remove the dressing not the dressing, but the taping, the bandage and everything, and clean up and, you know, replace it so it looks more presentable. But a lot of times you might have patients, even though you might have the NG tube in, patients are still like vomiting, and sometimes it doesn't come through the NG tube, like in terms of with you draining the stomach. Not all the time everything goes through the NG tube into the bag. Sometimes patients do carry up things. Sometimes it comes through their nose and causes mess on the NG tube. So it's just for you to make sure you try to clean up as best as possible. Read my comment before that. So let me just pull this up a little. Sorry, 1 minute. What are you taking? First time. Oh, yes, and lines must be clear. Yes, definitely the lines must be clear as well. But with the chest tube, a lot of times, you know, you might have the bloody discharge or the bloody secretions in the chest tube. So not all the time it's gonna be clear. All right, so it depends on where the tube is. All right. Because if it's in the stomach for your NG tube, it can come back clear, it can look green, it can come back yellow, depending on what it is. There's going to be different colors represented, you know, different things going on. Might be yellow, you know, bad looking. So for the chest tube, most of the time, it's going to be bloody. All right. And then from there. Where was I? Okay, let me go down to this one. All right, so the nurse, RN, assigns a UAP to obtain morning vital signs. The UAP reports a blood pressure of 80/40, heart rate of 120, respiratory rate of 32. What should the nurse do first? A, recheck the vital signs personally, document the findings. 3, ask the UAP to recheck or notify the provider. So you ask someone to assist you with getting some vital signs, and the person comes back with your blood pressure 80/40, heart rate of 120, respiratory rate of 32. What would you do? Recheck the vital signs personally, document the findings, ask the UAP to recheck or notify the provider. So A, Forever says check again. Definitely, Sammy. So you'll definitely go ahead and check the vital signs personally for yourself. All right. Sometimes if it means you have to go ahead and try to get a manual as well, go ahead and get your manual blood pressure, because not all the time with the automatic, you understand, will give you a good reading. So whenever in doubt, go ahead and recheck your vital signs for yourself. I know a lot of times it might be hard for us to, you know, be doing so many things. But you don't want it to be a case where you call the doctor or you start treating a patient for hypertension, tachycardia, and it wasn't a true reading. So always go ahead and double check. If it means you're going to recheck on the other arm, the leg, you know, things like that. You have different ways that you can go ahead and check. And always look at your patient, assess your patient. Because especially if the patient is not showing any signs or symptoms or having any symptoms off, then it's always good to go ahead and recheck to make sure that it is it is accurate. Manual blood pressure is lots of fun. Where are you working, Abby? Where are you working right now? Because I remember we used to do that a lot in Jamaica. Yeah, your manual blood pressure. All right, so always go ahead and double check whenever you have your abnormal you know, readings. Definitely go ahead and double check. And especially if you notice that, you know, so for example, you've had the patient all day and the vital signs was always normal or within that normal limit, you want to make sure that if somebody comes and say the blood pressure is like, you question it and say, no, let me go over there and check. You understand? Let me go over there and check. Don't just go ahead and document or start treatment on that, or call in the doctor and then only to find out that it was probably something that was positional or just incorrect. All right. So always recheck your vital signs first. A client so which client is most appropriate for the RN to assign to an experienced LPN? Is it a client receiving IV chemotherapy, a client requiring blood transfusion monitoring, a client with new onset of chest pain, or a client with stable chronic hypertension? So which client is most appropriate for RN to assign to an experienced LPN? A client requiring IV chemotherapy, a client requiring blood transfusion monitoring, a client with new onset chest pain, or the client with stable chronic hypertension. D, definitely. All right, remember that patient is on chemo IV. You also have someone that is getting their blood transfusion that you definitely want to be monitoring. And the new onset chest pain, you want to go ahead and talk with the patient, find out, assess the patient, see how the patient is doing. And then from there, you can manage. But the one that is stable chronic hypertension, you can always delegate to your LPN to go ahead and take care of that patient. All right. So which are appropriate UAP responsibility? That's the unassisted, unlicensed assisted personnel responsibility. Which is appropriate for them? Turning and repositioning clients, administering oxygen therapy, assisting with ambulation, monitoring pain levels, or documenting food. Oh, this is select all that apply. So which are appropriate for the UAPs? Is it turning and repositioning clients, administering oxygen? You're going to select all that apply. Administering oxygen, and assisting with ambulation, monitoring pain levels, or documenting food intake. I know it's going to be a little bit difficult with the select all that apply here. So A, C, D, okay. So we say turning and repositioning clients, all except D. So turning and repositioning clients, assisting with ambulation, monitoring pain levels, documenting food intake. Okay, so whoever says A, C, and D, turning and repositioning clients, assisting with ambulation and monitoring and documenting food intake is correct, all right? So everything except administering oxygen therapy, and even though, probably sometimes we might have the oxygen level at 2, and we say it's room air, the concentration of room air, it's still oxygen. It still requires an order, all right? And the monitoring is also something for the nurse, all right? So the UAP is not able to administer the oxygen therapy or monitor pain levels, all right? So they're able to turn, ambulate, and document the intake for the patient, all right? So they're not able to administer medications or do any form of assessments, all right? These are a little bit boring. All right. A client requires, which of the client requires immediate intervention? So you have 4 clients. Who do you need to run to first? A client with a tracheostomy whose inner cannula is plugged with mucus. A client with chest tube draining 100 ml of serosanguineous fluid per hour. A client with COPD with an O2 sat of 90% on 2 liters of oxygen via nasal cannula. And 4, or D, a client with abdominal surgery who has no bowel sounds at 24 hours post-op. So who is a priority here? Who requires you to drop everything and run to them? The client with a tracheostomy whose inner cannula is plugged with mucus. A client with chest tube draining 100 ml of serosanguineous fluid per hour. A client with COPD who is sat in at 90% on 2 liters of oxygen. Or D, a client with abdominal surgery who has no bowel sounds at 24 hours post-op. And we see a few A's. Holy file says C. All right, so A is the correct answer. The patient with the tracheostomy whose inner cannula is plugged with mucus. If that inner cannula is plugged, it means that this patient is not getting enough oxygen or getting any oxygen in their airways. So always remember A, B, C as priority when you're answering these questions, all right? So airway, breathing, and circulation. So anything that has to do with airway is going to be priority for that patient. I saw someone that said C, a client with COPD with oxygen saturation of 90% on 2 liters. That patient is good, all right? Remember, it's a COPD, so you're not going to be trying to get that patient's oxygen level to 95, 100, because they already have damage to the alveoli, so you're not expecting their sats to be, like normal. So those patients are going to be anywhere between like 88, 90. That is perfectly okay for that patient. Chest tube draining 100 mils of serosanguineous fluid per hour is pretty normal. So you always have to make sure you're looking at that. All right, and the client with abdominal surgery who has no bowel sounds at 24 hours post-op, definitely you want to go ahead and look at that. But it's not something that you definitely have to drop at that time. You understand? You don't have to rush to that patient immediately. Yes, you want to be concerned about whether or not this patient is having like, acute abdomen, things like those. But the one that is airway is going to be priority, and then you'll go with the others after. All right. And then from there. So the tracheostomy with the mucus plug is priority. This is an airway emergency. So definitely go ahead and check with that patient because the patient can lose patency of their airway. All right. So the nurse has 4 clients. Who should the nurse see first? Is it the client with cirrhosis who has ascites and 2+ leg edema? Is it the client with heart failure who has crackles and pink frothy sputum? A client with chronic renal failure with a BUN of 65 milligrams per deciliter? Or a client with COPD who is requesting oxygen for exertional dyspnea? So you have a patient or you have 4 patients. Who will you be seeing first? Is it the client with cirrhosis who has ascites and 2+ leg edema? A client with heart failure who has crackles and a pink frothy sputum? A client with chronic renal failure with a BUN of 65? Or a client with COPD who is requesting oxygen for exertional dyspnea? So Holy File says D, which is a client with COPD who is requesting oxygen for exertional dyspnea. We also have D. Lily says B, a client with heart failure who has crackles and a pink frothy sputum. Why do you say B, Lily? I see everybody saying D. Why didn't I follow everybody and say D? Why are you so special? Why you have to say B? What are you thinking about? Thank you for tuning in. Remember to go ahead and tap up the live. All right, let's see what Lily is saying, because Lily is not, saying what everybody else is saying. So Lily says, so the question, the nurse has 4 clients. Who should the nurse see first? And Lily says the patient with heart failure who has crackles and the pink frothy sputum. And what condition, what are you thinking? Okay, so honey bless. So pulmonary edema. Okay, definitely. So the answer is actually B, the heart failure patient who has crackles and pink frothy sputum. I understand that D is also a respiratory patient, or, you always want to look at ABC or airway, breathing, circulation. So you have two of them here. All right, so COPD who is requesting oxygen for exertional dyspnea. The patient with COPD is always going to be having, going to be feeling short of breath. So that is not a patient that you definitely have to rush to and see that patient first. The one that is having the heart failure who has crackles and is also having that pink frothy sputum has too much fluid on board. All right, so the patient has pulmonary edema, and that is going to impair their oxygen. So they're not going to be able to expand their lungs properly because there's just too much fluid there. So you always want to go ahead and address that patient. Make sure that they have good oxygen, flowing in their system. So the heart failure with the crackles and the pink frothy sputum is the one that is going to be primary. All right, the one that is chronic renal failure, the BUN is 65. The patient has chronic renal failure, so you're expecting it to be there. So, we'll eventually address that, but that is not a patient that you definitely need to run to. The cirrhosis who has ascites and 2+ leg edema, definitely you'll address that patient. But the patient has cirrhosis, the ascites and the edema are expected. So you'll go ahead and continue managing that patient. That patient, it did not show that, the patient has any issues with their respiratory system from that, ascites. Yes, they're probably going to be breathing, depending on the significance of, their ascites. It might cause impairment with their breathing. But in the question here, it did not really present that. So the pink frothy sputum, with a heart failure patient is going to be primary. All right. All right, let's see if we can top up the live to 6,000. I'm not going to be greedy. Just try to get the likes up so the video, it can get onto the YT page. That's what they call it, not YT, FYYP page. Yeah, so other persons can actually come on. And then from there, we'll look at the clues to see which is acute or chronic. Definitely, definitely. Sorry, 1 minute. Hello? Yes, I'm on the live. Sorry about that. All right. So always look at the question and then from there. And I always say, while you have your patients here, always think about your differential diagnosis. When you're thinking about your differential diagnosis, that will help you to tell which patient is, at risk for dying first or decompensating. The prognosis is going to be poorer for that patient. And then from there, you can always address that patient. All right. So always think about a different differential diagnosis while you're answering the questions. Look at them and see, okay, what is going on with this patient? They might present with, different signs and symptoms, or the question might present that to you, but what is going on with that patient? All right. A client should be assessed. Which client should be assessed first? A client with a femur fracture in box traction. 2, a client with a cast who reports numbness and pain unrelieved by opioids. 3, a client with rheumatoid arthritis with morning stiffness. A client with osteoporosis who needs fall education. Thank you, Honey Bless. Thank you for tuning in and for saying that. Okay, so Carousel says B. All right, do we have anybody else? So a client, you have all of these 4 patients. Which patient do you need to assess first? Is it the client with a femur fracture in box traction? A client with a cast who reports numbness and pain unrelieved by opioids? A client with rheumatoid arthritis with morning stiffness? And a client with osteoporosis who needs fall precautions? So we have one answer there, B. Can we get another one? All right, remember you're at the bedside with these patients and you have these patients in front of you. So you have to do something or else your license is going to be taken away from you. All right, so what are you going to be doing? Who are you going to be seeing first? Is it the client with a femur fracture in the box traction, the client in the cast who reports numbness and pain unrelieved by opioids, a client with rheumatoid arthritis with morning stiffness, or the client with osteoporosis who needs fall education? So Lily says D, all right, which is a client with osteoporosis who needs fall education. All right, so the answer is actually, I think I saw someone had said B. Carousel says B. A client with cast who reports numbness and pain unrelieved by opioids. Why are you concerned about that patient though, Carousel? Why are you concerned about a patient who is still having pain and numbness? Take it in like, I heard relieved. Oh, sorry, unrelieved. My bad, Lily. Unrelieved, my bad. So why are you concerned about that patient? Why are you going to go to that patient first? Because the patient is on narcotic compartmental syndrome, yes. All right, so you have a patient who is in a cast and the patient is having a lot of pain. Yes, perfusion issues. You're having a patient that is, you have a patient that is in a cast or plaster of Paris, POP, and the patient is on narcotics. The patient is having a lot of pain. And even if they don't say that they're having the numbness, you understand? If they're having a lot of pain that is unrelieved by the narcotic or the pain medication, the first thing that you're thinking about is compartmental syndrome. So with compartmental syndrome, you want to make sure that, what are you going to be doing? Oh, I'm muted. Battery dead. That's all? Hold on. Are you hearing me? Oh, just come back. Okay. All right. So for the patient, okay, nice. So for the patient, when you have the patient, so even if the patient is not reporting the numbness, the mere fact that they're on the narcotics, not getting any relief, and they have the cast on, and especially if they're having the pain in that area. One thing that you will be concerned about is the compartmental syndrome. All right. So definitely go ahead and assess that patient properly. Let the provider know, and then from there you can always go ahead and save the limb. And what is one thing that when you think about a patient that has compartmental syndrome, what is one thing that you're thinking about at that time? So the patient is having the pain and you're thinking about it. You look at the leg and you realize that, it is pale. The patient doesn't have much sensation there. What is it that you're going to be doing to help with relieving the pressure there in that limb or with that cast on? What is one way for us to go ahead and just quickly do that? Help with relieving the pressure. So if you're on the orthopedic foot, okay, elevate, okay. But you elevate the leg and the patient still have a lot of pain, and the patient leg just still look pale. You can continue to elevate it. Where you go for you go elevate it to now? So you elevate the leg and the patient still having pain. What are you going to be doing? You're calling the doctor and the doctor is not answering the phone. You understand? It's to go straight to voice message. The doctor is on calling and it's to go straight to voice message. What are you going to be doing? What are you going to be doing? What are you going to be doing for that patient? The patient is like, nurse, I can't take it anymore. I cannot take it anymore, nurse. What are you? Loosen it. Okay, cut it open. So that's important. So if you're working on the orthopedic floor, you definitely need to find out where they're keeping that saw. Especially if you have a lot of patient that has cast on. You definitely need to know where that those saw is. So that way you can evaluate. You can evaluate a patient and go ahead and do whatever it is that you need to do. Because if in the event that you're there, it's 12 o'clock, 2 o'clock in the morning, and you have that patient with a cast on, and you're calling the doctor and you're not getting through to the doctor, and you identify that this is what is going to be happening, go ahead and get somebody to help you with, loosening up that cast. Help with cutting it. You understand? Help with cutting it, because you can always put on back the cast. You understand? But you want to go ahead and help with relieving that pressure on that leg or that limb at that time. You can always, yes, it can always go back on. All right. But you don't want it to be said that, you never do it. And then by the time the doctor do answer the phone or see the missed call or whatever, get to the hospital, the patient lose them limb. So that's the last thing you want to do. All right. So always remember to do that. When it comes on to your, when you have a patient especially on the orthopedic floor, you always talk about the different P's. Can we talk about some of the P's that we're looking for with our patients when it comes on to the limb? So what are we checking for? I think it's the 5 P's. Yeah, and we're not talking about the P's, the P to go to the bathroom. P's, pain, pallor, okay. Anything else? Paresthesia, yes. Pulselessness, yes. Pain, pallor, pulselessness. There is one. Which one? One that is missing. Pain, pallor, pulselessness, paresthesia. Are we missing one? I'm trying to remember 5 P's. For pain assessment. There is one that we're missing. Paralysis. All right. So you have the pain, pallor, pulselessness, or pulse, paresthesia, and paralysis. All right. So those are what you're going to be checking for to make sure that you have, adequate blood flow, or you're not having compromise in terms of the blood flow to that patient's limb. All right. So definitely do that. You want to make sure you're preserving that nerve function in that patient. All right. The femur fracture in the box traction. You will eventually assess that patient. The rheumatoid arthritis with the morning stiffness, usually you'll tend to have that. So that is normal. Osteoporosis who needs fall education. Definitely you'll educate all of your patients regarding fall, your fall precautions. But especially for your osteoporosis, you want to make sure you're educating them. Why are you educating somebody with osteoporosis about falls? How to prevent falls? Why? Why are you concerned? Why are you so concerned about, the falls with these patients? A patient has osteoporosis. What's the difference between the patient having osteoporosis and the patient having, you know, hypertension and the patient having, what else? The bones are brittle. Yes, definitely. So the bones are very brittle. So you want to educate those patients and tell them that, you know, try not to fall because, you know, you might break a few bones. All right. You might break a few bones. The bones are already weak. Yes. So you want to educate them and let them know, you know, just to be very careful. All right. Yes. All right. So the client, so which client must the nurse sees first? A client with pneumonia with a temperature of 100.4, a client with asthma who is wheezing and oxygen saturation of 89, a client with migraine requesting pain medication, or a client post-thyroidectomy complaining of tingling lips. Who will you go ahead and see first? So you have a client who has pneumonia. The temperature is 102.4. The client with asthma with wheezing and oxygen saturation of 89. The client with migraine requesting pain medication. Or the client post-thyroidectomy complaining of tingling lips. All right, so BBB, which is the asthma patients with who is wheezing and the oxygen saturation is 89. But the 89 is almost close to 95. You know, I think. Why are you so concerned about that one? The client with the asthma and the wheezing and the oxygen is like 89. You know, what if the patient is like, you know, what if the normal oxygen saturation for this patient is like 90? Why are you so concerned about this one? Why are you not concerned about the patient that is frying? You have somebody with pneumonia and the temperature is like so high. Like, why you want to be concerned about that one? So, okay, so we are using the same airway breathing circulation, but the asthma patient with wheezing, definitely airway is wheezing and the oxygen saturation definitely will get critical first, faster. All right, so you want to make sure that, you know, those alveoli, you know, you want to make sure the airway is not compromised. So definitely get that oxygen and your nebulization treatment going for that patient to help with opening those airways. All right. The patient with the pneumonia and the temperature of 104, 102.4, with the pneumonia, you're expecting to be having the fever. You can always go ahead and start your antibiotic, you know, your tepid sponge bath, things like those. Give your antipyretics. You know, go ahead and do all of those, and then from there, you know, get the temperature down. Doesn't really need you to go and see that patient first. All right. Patient with migraine requesting pain medication. Eventually, you'll get to that one. What about the patient who is having the tingling lips? Post-thyroidectomy, complaining of then deal with the lips. Yes. So what about the patient with the the thyroidectomy complaining of the tingling lips? What are you concerned about with this patient, the thyroidectomy patient? What are you looking at in terms of, okay, hypocalcemia, definitely. All right, so remember that this patient took out their, you know, remove their thyroid gland, and, you know, there is going to be the risk for hypocalcemia. So you definitely want to be monitoring that patient. It's an emergency, not really a life-threatening emergency, but this is something that you definitely need to address. All right, but not as immediate as the airway. All right. The client, so which client should the nurse assess first? You have a patient that has DKA, diabetic ketoacidosis, with glucose of 420. You also have a client with COPD with a pH of 7.3 and a PaCO2 of 55. You have a client with acute appendicitis with abdominal guarding, or a client with influenza reporting generalized muscle aches. So you have a client with, which client should the nurse assess first? Who are you going to be seeing? Is it the client with DKA with blood glucose of 420? Is it the client with COPD with a pH of 7.3 and a PaCO2 of 55? Is it the client with acute appendicitis with abdominal guarding? Or a client with influenza that is reporting generalized aches? Who will you see first? So is it the DKA patient, the COPD, the acute appendicitis, or the influenza patient? Who are you going to be seeing? So we know that okay, so Holy File says C, which is the client who has appendicitis with abdominal guarding. Carousel says B, the COPD with a pH of 7.3 and a PaCO2 of 55. Okay, so do we have anybody else who wants to answer? What are you concerned about, Carousel, with B, the COPD? So Lily says C, which is acute appendicitis with abdominal guarding. Okay. So respiratory acidosis. Okay, okay. So she's concerned about respiratory acidosis in this patient. All right, so as we said before, always look at the answer and try to use the ABC to try and give you a clue as to how to go ahead with answering the question. With the COPD, if you know the different, your ABGs, so this question, you have to know your ABG, your lab values. And then from there, you will be able to answer the question, all right? So the pH of 7.3, what is a normal pH? What is a normal pH? And I always have to be writing down when it comes on to the ABG. I always have to be writing down to try and remember them. All right, so you have to know your ABGs in order to answer this question. So 7.35 to 7.45. Your CO2 is gonna be what? And always, what is gonna be your CO2? You can always use your pH to help with answering or knowing your CO2. So the CO2 is gonna be what? 35 to 45? Or 22 to 26? Okay, hold on there. 22 to 26. Okay, so the pH is gonna be 7.35 to 7.45. Your CO2 is gonna be your 35 to 45. Okay, so you use the pH, the ending of your pH to find out the 7.35 to 7.45, which is a normal. Just take off the 7, and then the 3.5 to 4.5 is gonna be your CO2. Okay, CO3. Okay, and then now your bicarb is gonna be 22 to 26. All right, so the one that he gave me was the bicarb carousel. And then your oxygen is going to be the 95 to 100. So if you're able to tell what the normal is, then you'll be able to, help with answering the question. All right, so the 7.3, that is going to be acidic. And the CO2 of 55 is going to be... So the CO2 of 55 is going to help with you answering the question because the CO2 is the respiratory, all right? So that is going to tell you that this patient is in respiratory acidosis, all right? So the COPD with respiratory acidosis is the one that you're going to be addressing first, all right? That is going to be your priority. DKA with a glucose of 420 definitely is, your DKA patients are always priority, but they never really give you anything else with this patient. Apart from the glucose, you'll eventually go and address them. Acute appendicitis, the acute appendicitis with the abdominal guarding, yes, it's an emergency, but it only says that the patient is guarding. So definitely you can hold off a little on this one, but watch them like a hawk, you understand? And then the influenza patient who is reporting generalized muscle ache, pretty common for, your flu patients. So definitely your respiratory acidosis is gonna be the one that is priority because it's airway. You want to address that one, and then you go on to your appendicitis. All right, and then from there. So a client, which client is priority? A patient with hypovolemic shock with heart rate of 140 and the blood pressure of 78/40. A client with Addison's disease on prednisone. A client with diabetes with glucose of 250, or a client with hypothyroidism who is constipated. Which client is priority here? The client who is hypovolemic with a heart rate of 130 to 78, blood pressure of 78 over 40, the client with Addison's disease on prednisone, the client with diabetes whose glucose is 250, or the client who has hypothyroidism who is constipated. Which one is your priority patient? So the hypovolemic shock patient is going to be priority. All right. So the patient is tachycardic. The patient is compensated because the blood pressure is already low. Patient is hypotensive. Blood pressure of 78 over 40. So this patient, how are you going to be managing this patient? What are some things you can do in the meantime to manage this patient or to help with the patient's blood pressure? Lily says A, yes. So how can you, so you have this patient, you go in the room and you realize this patient is heading into hypovolemic shock. What can you do for this patient in the meantime to save this patient's life? IV fluids and your vasopressors. Okay, nice, nice. All right, so definitely you want to do that. What about positioning? Is there any special positioning that you can do with this patient? If you have a patient that is in hypovolemic shock, is there any position that you could put this patient in? Would you put this patient in like in a sitting up position, like a high Fowler's position, semi-Fowler's position, triangular, that word? Yeah, it's always a tongue twister. All right. Are you able to put that patient in any of those position, reverse? Yes, yes. All right. Trendelenburg position. So definitely you can always do all of those things in the meantime for your hypovolemic shock patient. Would you go ahead and get a little IV down here, or where would you go ahead and get your IVs? How many IVs would you get on this patient? So definitely want to go ahead and get your two large bore IVs on this patient. All right, try and get your IVs up here, but wherever you can get it, but always start with, you know, the ACs, you know, it's closer to the heart, so you always be able to get your fluids going in faster. And then from there, you try to see if the patient could benefit from a central line, depending on how severe, you know, that shock is, or the blood pressure is, or the patient is. Because sometimes you can have, you know, your patients in hypovolemic shock and or they're heading down that direction, and you give them a small amount of fluids and you look, blood pressure goes up. You understand? So not all the time you rush to get the central line, but always try to make sure that you have your two large bore IVs. You get your patients on some fluids, you know, put on your pressure bag and get those fluids going in. All right, the client with Addison's disease on prednisone. Are you concerned about that patient? Patient on prednisone? Or is that going to help with their Addison's disease? It's going to help with their, you know, it's going to help with their Addison's. So prednisone is a corticosteroid medication that is used as a replacement for the hormone cortisol in the treatment of Addison's disease. All right. Since Addison's disease is a lifelong condition where the adrenal glands do not produce enough cortisol, patients must take medication for the rest of their lives. All right. So they always use prednisone, which is a synthetic form of the glucocorticoid hormone. So that patient is important, but, you know, not a priority. The client with diabetes whose blood glucose is 250 is the same. Diabetes, the glucose is going to be elevated. Just go ahead and make sure you're monitoring to try to get that number down. And the client with hypothyroidism who is constipated, is that is constipation a side effect or not side effect, one of those symptoms of hypothyroidism? Or is it diarrhea? Which one? So you have a patient that is hypothyroid, has hypothyroidism, and the patient is complaining of constipation. Is that normal, or is it diarrhea they're supposed to be having? Which one? Yes, you can always go ahead and elevate their legs, carousel. Yes, you can always elevate their legs because that helps with the flow of the blood back to the heart. Definitely. Yes, so with hypothyroidism, constipation is pretty normal for them because what's happening with their metabolic rate? it's slowed. So just think about everything that is slowed down. So you're not expecting that patient to be having diarrhea. All right. So they're going to be having, they're going to feel as though they're constipated. Their skin is going to be very thick, and, they're always going to be probably cold, things like those. All right. So know the difference between the hypothyroidism, and if you can think about what the thyroid gland is supposed to be doing, you understand, then you will be able to help with answering the questions. Because especially with the hyperthyroidism, if your metabolic rate is increased, you're thinking about everything that is going to be happening fast. The patient is going to be losing weight faster. The patient is going to be sweating. The heart rate is going to be high. Patient tend to have diarrhea, things like those. And then with hypothyroidism, you think about the metabolic rate being slowed. So everything is going to be slowed down. The heart rate is going to be slow. The patient is going to be constipated. The patient is always going to be cold. The patient is going to be obese. You understand? Because it's hard for them to lose weight. Things like that. All right. So the answer, as we say, is the hypovolemic shock, severe hypotension, and tachycardia. Those impaired your perfusion. That patient is considered to be unstable. So you want to go ahead and address that patient first. All right. Okay. So which client requires, immediate attention? Is it the client with a post-op drainage of 200 mils in the last 2 hours? The client with a new tracheostomy with difficulty breathing? A client with nausea and vomiting after chemotherapy? Or the client with CHF who has gained 2 pounds in 24 hours? So which patient requires immediate action or attention? And when we talk about immediate, we're talking about you drop everything and run. All right. So all of the patients are going to need your attention, but who do you need to go to see now? All right. Is it the client who has 200 mils of sanguineous drainage in the last 2 hours? The client who has a new tracheostomy with difficulty breathing? The client with nausea and vomiting after chemotherapy? Or the client with CHF who has a 2 pounds, weight gain in the last 24 hours? All right, the tracheostomy patient, definitely, as we say, airway. And with this patient who has a new tracheostomy and is still having difficulty breathing, you want to make sure that that airway is patent. So you always want to go ahead and address that patient. Nausea and vomiting after chemotherapy, usually it's pretty common for them to be having the nausea and vomiting. So it depends on the amount as well. You understand? CHFer who has gained 2 pounds in 24 hours, yes, definitely. That is something that needs attention. It means that if the patient is on some loop diuretics like furosemide, those water pill, it means that the medication not working. So you probably need to go ahead and increase it to the IV dose or whatever it is. You understand? But that is not something for you to drop and say, okay, then. All right. You definitely need to run and see that one. So the new trach with difficulty breathing, you're thinking about airway obstruction. You're thinking about something that is life-threatening. You want to address that patient. You understand? You want to address that patient first. All right. Which client is the highest priority for you here? Is it the client with pancreatitis and severe abdominal pain? Is it the client with ulcerative colitis having 6 watery stools today? Is it the client with peritonitis and a rigid board-like abdomen? Is it the client with GERD and frequent heartburn? So you have these 4 patients. You just get the report. You need to go and see one. Who is it that you're concerned about and you're going to go into that room to check on the patient? Is it A, the client with pancreatitis and severe abdominal pain? A, the client with ulcerative colitis having 6 watery stools today? C, the client with peritonitis and a rigid board-like abdomen? Or D, the client with GERD and frequent heartburn? Who are you going to be seeing? Carousel says C, the client with peritonitis and rigid board-like abdomen. Do we have anybody else? So we have the pancreatitis with the severe abdominal pain. We have the ulcerative colitis. Ulcerative colitis who is having 6 watery stools today. A client with peritonitis that has rigid board-like abdomen. And the patient with GERD and frequent heartburn. Why are you concerned about that patient with the peritonitis though, Carousel? The patient has peritonitis. Why are you so concerned? The patient tummy just tender. You know, patient tummy just tender. Why are you concerned about the perforation? Definitely. All right. You're definitely concerned about perforation. You're definitely concerned about sepsis. Those are life-threatening. So you want to get that patient prepped for the OR, you know, so you can always go ahead and do their exploratory laparotomy. You know, go and do their surgery to find out where, you know, you have like a obstruction or necrosis or whatever is going on in the abdomen. So definitely, you know, you want to look at that patient first. What do you be feeding this patient? Would you be feeding this patient? Would you be feeding any of these patients? What if the patient tell you that, nurse, I'm just thirsty, I need something to drink? Would you go and get that, you know, soda for the patient? No, definitely you want to keep all of these patients NPO, nothing by mouth, all right? So all of these patients you'll keep NPO, not necessarily for the GERD. You can give the patient with the GERD, you know, something, but all the other patients you definitely probably want to, you know, hold off on anything for them. And the ulcerative colitis as well probably could get something to drink. All right, but the peritonitis and the pancreatitis with the severe abdominal pain, definitely NPO those two patients, and then from there. All right. So the rigid abdomen with the peritonitis is the one that is concerning. B, the client is at risk for dehydration. Yes. So client with ulcerative colitis having 6 watery stools today is at risk for, you know, dehydration, but it's not like, you know, so they have 6 watery stools today, so they can still wait a little, you understand? They just have 6 watery stools today, they can wait a little. Pancreatitis with the severe abdominal pain, definitely you don't want to be monitoring that patient. And we said it the other night, what is the one thing that you're thinking about with the pancreatitis patient that you need to keep an eye on? You're already not feeding them because, you know, they have the pancreatitis and they're having the abdominal pain. So what is it that you're concerned about for these patients? So you have the patient, you're not feeding the patient because the patient is NPO and the patient has pancreatitis. What is it that you're concerned about for this patient in terms of vitals, monitoring and all? Are you concerned about their glucose? Because what we know about the pancreas, if your pancreas is already inflamed, giving problems, what is happening here? The patient is at risk for, who you ask? May I ask you, Shelly? You may ask. Welcome to the live. All right, so the patient is at risk for hypoglycemia, all right? No, hypoglycemia, not calcemia, carousel. So the patient is at risk. I think you're saying, I think you were the one who said it the last live. The hypoglycemia. So the patient is at risk for the hypoglycemia. All right, because you're going to have impairment with those insulin. So definitely you want to go ahead and check those patients' glucose around the, yeah, that's what you wanted to text. You want to go ahead and check those patients. You want to go ahead and check the patient's glucose. Okay, all right. So definitely keep an eye on the patient's glucose when you're monitoring them. Shelly says, me and a nurse, you fit tell us. All right. But I hope that answers your question, Marv. All right. I hope that answers your question. So risk for perforation. Definitely, yes. The peritonitis is at risk for perforation. All right. So definitely go ahead and make sure you're checking that patient and then from there. All right. So you have a client, or which client should the nurse see first again? All right. So is it the client with hypoglycemia who is unconscious? The client with hyperthyroidism that is reporting heat intolerance, the client with cirrhosis with ascites, or the client with chronic kidney disease reporting pruritus. All right, so who will you see first? Is it the client with hypoglycemia who is unconscious, the client with hyperthyroidism reporting heat intolerance, the client with cirrhosis and ascites, or the client with chronic disease reporting pruritus? Yes, definitely the hypoglycemic patient is the one that you're going to be seeing first. So definitely the patient is hypoglycemic and the patient is also unconscious. You're thinking about what? Thinking about the patient in coma. You're thinking about those seizures there because the hypoglycemia can cause, the seizure. So you want to make sure you address the patient that is at risk for life-threatening issues. So that patient is one that you'll definitely address. And not only that, you realize that you have the patient that is unconscious as well. So that is also going to be an airway problem, because if the patient is hypoglycemic and unconscious, probably the patient is not able to protect their airways. So you want to go ahead and address that patient, make sure everything is fine. All right. So that's a safety question there as well. The hyperthyroidism patient that is reporting heat intolerance is pretty normal for your hyperthyroidism patient. All right. Your client with cirrhosis and ascites, you will eventually get to that patient. And the client with your chronic kidney disease reporting pruritus, you can always go and address later on as well. With a patient with cirrhosis and ascites, what is one thing that you're concerned about with this patient? Patients that have cirrhosis of the liver. What is one thing you're concerned about with those patients? Shelly Marv. Okay, no problem, Shelly. Definitely. So you have a patient that is in the hospital. You're concerned about dying. Okay. All right. But in terms of when you're thinking about the lab values, what are some things that you're gonna be looking at with this patient? So you have a patient that has cirrhosis of the liver. What is one thing that you're looking at? You're keeping an eye on for these patients? The ammonia level, yes. Yes, Shayna and Carousel. Definitely you'll be keeping an eye on your ammonia level. You'll be keeping an eye on whether or not this patient is getting confused, things like that. All right, so always keep those in the back of your mind, that this is what is happening, and so you can always manage your patient as you go along. All right. And then from there. All right. So you have 4 patients that are pediatric clients, all right? Who is going to be priority? All of them are priority. Even if you come with cough and cold, they're priority. All right, but out of the 4 that you have right now, who is it that you're going to drop everything and run to? Is it the child with epiglottitis that is drooling and sitting upright? Is it the child that has otitis media with a fever of 101 degrees? An asthmatic child that is using albuterol inhaler before going to the gym? Or is it the child with sickle cell disease with mild joint pain? So you have 4 pediatric clients. Who is priority? The child with epiglottitis, drooling and sitting upright. The child with otitis media with fever 101 degrees. The asthma child that is using albuterol inhaler before gym, or this child with sickle cell disease with mild joint pain. All right, so I see here fever, airway, asthma, AAA. All right, so whoever says A is correct. So Shayna, Carousel, yes, definitely those are the ones, the patient with epiglottitis. And one thing I would say is anytime you see epiglottitis, just choose the answer there. If you don't know, just choose the one there. There's a high possibility that is the patient that, is priority for the scenario. A lot of times I tend to see the epiglottitis question, and that is always the answer. I'm just saying, if you don't know which one to choose, always go ahead and choose the one that has the epiglottitis. All right, if you're asking you for priority, because you're thinking about, the obstruction there. So definitely go ahead and save that patient first. All right. So the child with epiglottitis and is drooling and sitting upright. So the mere fact that the patient is drooling, it means that they're not able to what? There is some form of obstruction going on. So the fluid is actually just running out. They're probably not able to swallow properly, to get that secretion down. So it's coming out of the mouth. So definitely you want to go ahead and address that patient. All right. So the airway is obstructed there. The child with otitis media, which is the ear infection. All right. the ear infection that has the fever of 101, that is pretty normal for otitis media for them to have that. It's not a dire emergency, so you can always give them medication. Most of the time they end up go back home after you see them in the hospital, the emergency room, depending on what's going on as well. You understand? Because sometimes they can have the otitis media and they have other problems going on where they're not eating, drinking, things like those. But it depends on the situation. But the otitis media with the fever of 101 can wait. All right. Child with asthma using albuterol inhaler before gym. The asthmatic patients are always emergency as well. But just remember that this patient is currently using albuterol inhaler before gym. So, you know, that patient is probably not that sick right now, depending on what is going on. All right. The child with sickle cell disease with mild joint pain. Mild joint pain is an expectation for sickle cell patients. So it's not like, you know, you're not thinking that this patient is in crisis at this time. Out of all the 4 patients, run for the epiglottitis patient. Then you can go down to your, you know, you can go to your asthma patient, depending on what the vitals and how the patient looks. Your sickle cell patient with a mild joint pain is also going to be one. So you want to make sure you get your fluids going to help with, you know, getting those sickle cell, you know, go moving through the vessels and preventing that occlusion that is causing the pain. Your otitis media patient, I think, is going to be the, you know, the last one I'll run to. You understand? The last one, because it's the ear. So definitely you would do that. But the risk for airway obstruction with your epiglottitis is always going to be your primary or your priority patient in that situation. All right. Oh, may I learn something on TikTok? Yes, TikTok is, you know, TikTok is a platform that a lot of things can happen on. I kind of love TikTok now. I'm loving TikTok. Initially, I wasn't a fan of TikTok, honestly, but I'm starting to love TikTok. Yeah, I'm starting to love TikTok from when I started using it. So I'm happy you are. Make sure you go ahead and follow though, you know, and tell all your friends about it. All right, so they can come over and enjoy a bit of, you know, nursing knowledge here. I'm learning to read. Not a problem, Charlene. Not a problem. Thank you. So I try to do the live on Tuesdays and Thursdays. On Thursdays, it will go a little bit longer because I'm not working tomorrow. So I can always definitely, I can always go a little bit longer. Dion Brown. Okay. I can go a little bit longer on Thursdays, but on Tuesdays, I probably go up to like, you know, 1.5 hours, and then from there. I'll check my messages, Dion Brown. Okay. Okay, I'll definitely get back to you, Dion. Okay, I'll text you shortly. Dion. All right, I'll text you back. All right, not a problem. All right, so let's go on to this one. Which client is priority? A client with DVT with swelling and warmth in the leg. A client with pulmonary embolism with sudden dyspnea and a chest pain. A client with diabetes and neuropathy reporting tingling. A client with anemia reporting fatigue. Which of these patients is priority for you? The client with DVT with swelling and warmth in the leg, the client with pulmonary embolism with sudden dyspnea and chest pain, the client with diabetes with neuropathy reporting tingling, or the client with anemia reporting fatigue. Definitely. So all of you says B, which is a pulmonary embolism patient with sudden dyspnea and chest pain. So that patient is at risk for, you know, perfusion issues, airway compromise, things like that. So PE, pulmonary embolism, is a life-threatening problem. So you want to go ahead and run to that patient, start all the different things that you're supposed to be doing. So definitely want to go ahead and get your 2 IVs. What else are you thinking about with your pulmonary embolism? What drug are you thinking about that you will be expecting to start? So you have a patient that has a clot. What are you going to be starting for that patient? So heparin or whatever blood thinners, yeah, they order. So definitely you're expected to start your blood thinners. All right, your heparin infusion. All right, so you definitely want to go ahead and start that. What else can you be doing for this patient? So blood thinners, definitely. What else can you be doing for this patient? So you have this patient that has a pulmonary embolism. The patient is dyspneic or having shortness of breath. The patient is also having chest pain. What else can you be doing for this patient in the meantime? So before you go and get your heparin, started, because remember the doctor put in the order for the heparin, and you have to wait for the pharmacy to verify it, and you have to do this and all of those things. What else can you do? Yes, you can go ahead and get your oxygen going because you want to make sure that you're perfusing properly. Definitely. What else are we going to be doing? So this patient is lying down in the street clothing, just like how me the years is don't look on you. You understand? What else can you be doing for this patient? Increase hydration and oxygenation, definitely. All right. What else can you be doing for this patient? Blood pressure check, okay. Would you be getting this patient on the cardiac monitor? Are you not really, probably high Fowler's position, okay, okay. How would you go about with managing this patient? So the patient come in and you realize that, the patient says, yes, I have a history of PE, the patient is sweating, the patient is short of breath, chest pain, all of those things. What can you do for this patient in the meantime? So some of the simplest things that we can do to make our life easier as a nurse. What can we do? We have the patient come and the patient lie down on the bed, and the patient is in the jeans pants, and the patient is in the nice little jacket, well tucked in. What are we gonna be doing? I do that for all of my patients. Nurses will tell you that they're annoyed, especially my techs, especially if the patients are not, like walkie-talkie. Like they will tell you, say, Stacey, why you always want to take off the patient clothes? Like, yeah, get that patient out of them clothing, cool them off, make them comfy. Definitely. Get them out of them clothing, take off them clothing, get them on the EKG machine, the cardiac monitor. So take off their clothing, get them onto the cardiac monitor, start getting your EKG, get your IVs, going. Get your 2 large bore IVs on that patient, lightening the clothing. Definitely. Literally take off them clothes and put them in them birth clothes. That's how we do it. You understand? Them can't keep on them underwear, I'm not really want anything for hinder me from getting to my patient's chest whenever I'm ready. Can you imagine you have a patient, that is having chest pain, and the patient is lying in bed in clothing like this? That is going to be too much work for you later on. You understand? You're going to have to be going underneath to put on the EKG, electrodes. And then, so for example, the patient start cold. They always say, make hay while the sun shine. Take off the patient clothes from before. You understand? Expose the chest and get your leads. Get the patient connected. Get your pulse oximeter on in the meantime while you're waiting on your orders to be verified. And then from there. You understand? Thank you. Get all of those going until you get your order for your medication verified and started. All right. And you're thinking about like your pain medication as well. So you can always get your pain medication going for this patient. All right. And you're thinking about like, you remember the same acronym for the MONA? You use the same MONA acronym to help with this management as well. So you're thinking about your morphine, your oxygen, not your nitroglycerin, all right? But you're gonna be using that same management to help with your PE patients. No, I'm a nurse, Don Faulkner. I'm a nurse here, okay? All right. The client with diabetes with neuropathy reporting tingling. Eventually, most of the time, patients will tell you that they're having neuropathy because of the fact that, they're diabetic. You have the nerve damage to, that is going on. So a lot of times they will tend to have the tingling sensation, the paresthesia, because of their diabetes, all right, which is one of the complications. So patient is still a priority, but, not a priority for this, for your 4 patients that you have right now. One thing you're concerned about with the diabetic patients and neuropathy. So the patients are at home and they're having the tingling, the numbing sensation or the paresthesia as a result of their diabetes. One thing that you're interested in is what? Or one thing you're going to encourage them to always do is what? In the fingers and toe. Yes, so they're always at risk for injury. So you always want to encourage them to go ahead and be checking their, their foot. You understand? Mona, not for MI. Mona is for MI or ACS. Acute coronary syndrome. Yeah. So So you always want to make sure that they're checking their, their foot, for any injury, because if they already have the paresthesia going on, there's a high possibility that if they do step on something, they won't even realize. And so you don't want them to be, stepping on things, getting like, an injury, and then having problems with wound healing. All right. So that is one thing you really want to be very, very careful when it comes on to your diabetic patient. The client that is anemic and reporting fatigue. Fatigue is going to be, if you're anemic, you're going to feel fatigue, and that is something that, not an emergency, but you can always address it, all right? Because you still want to know how far that anemia is in terms of the hemoglobin, how low the hemoglobin is. Because if it is 2, you definitely want to drop everything and run. You understand? You definitely want to drop everything and run. But if you had the hemoglobin of 2 and you also had the pulmonary embolism patient, who are you going to run to first? Who are you going to run to first? So if you have a patient that has anemia, who is anemic, severe anemic, and you see that the anemia or the hemoglobin is 2 or 3, all right, which is very, very low, and you also have a patient that has pulmonary embolism, who is dyspneic and chest pain, who would you run to first? The low hemoglobin, okay. Do we have anybody else? Love from, hey, where are you from? I am from Jamaica, Mind Maze. All right. So always still use the, still always use your airway, breathing and circulation to answer your question. All right. Always still use your ABCs to answer your question. Airway, breathing, circulation. But say, for example, the patient end up code no. You understand? Who you will run to first? What if the anemic patient code? You don't see anything on the monitor. You just see a flat line. Who you going to run to? Yeah, you're going to run to, are you going to run to your embolism patient still, or you're going to let the flat line just be a flat line? Put you on the spot? Yeah, to put me on the spot too. There are different things you're going to have to take into consideration, and then from there you make it, your judgment call from there. All right, but hopefully there is going to be some help or some assistance, someone passing by that you can actually say, hey, let me run over to the flat line, and you deal with the PE. You understand? Because that patient is still talking. Yes, the patient is having the chest pain, but the flat line is going to be, if it's a real flat line, if it's a true flat line, not a flat line because the EKG, electrodes drop off of the patient's chest. You understand? So make sure you look at the monitor and look at the patient. So if the patient is flat line and on the monitor, but you look and you realize the patient is texting on the phone, then you can continue to go to your, your PE patient. All right, and then from there. Hi, Vanessa, how are you doing? So both of them in critical position. Yes, both of them are critical. So you have to just go ahead and make this decision from there. And that's why it comes back down to, assessment. So eyeball your patient and see who you need to run to first based on what is happening. All right. All right. So you have 4 clients. Which one should you assess first? You have a client with sepsis whose blood pressure is 80/50 and a heart rate of 132. You have a client with angina, stable angina, who requests nitroglycerin. You have a client with COPD who's sat in at 91% on 2 liters. Or you have a client with kidney stone who is reporting flank pain. Who will you assess first? Is it A, the sepsis patient who is hypotensive and tachycardic, the client with stable angina who presents or requests nitroglycerin, the client with COPD whose SAT is 91%, or the client with kidney stone reporting flank pain? Who would you go and see first? All right, so A, nice. So the patient who is sepsis with blood pressure of 80/50 and a heart rate of 132. The stable angina, is the word there, stable. So that means, the patient is over there, watch TV and look decent in a bed on them phone tablet, making them phone call. They just need, a nitroglycerin because they feel as though the chest pain is coming on. So definitely you'll address them, but you want to run to them first, all right? The client with COPD whose SAT is 91% on room air or on 2 liters of oxygen. That's a COPD. The 91% is pretty decent for that patient. So you don't need to drop everything and run to that patient. And then you have your client with the kidney stones reporting flank pain. Definitely you will address that patient as well. All right. But the first one is going to be your sepsis patient. is going to be your sepsis patient with the blood pressure of 80/50 and a heart rate of 132. So you have this patient that is in sepsis. What are some things that you're anticipating? So you're trying to get to the doctor. You have this patient here. The patient is not a heart failure patient, all right? It's not a heart failure patient. The patient is in sepsis. Blood pressure is low, 80/50. Heart rate is 132. You check the temperature, it's 104. What can you do for COPDs get what can you do for that patient in the meantime? Or if it's a very busy floor and you're the only nurse on the floor, or if you have 2 nurses, 10 patients, you know, what can you do in the meantime for your patient there? So, you know, you're waiting on the doctor's order, but you have a little time on your hands. So you decide that, you know what, I'm not going to stay on TikTok anymore, you know. I'm going to just go ahead and just be proactive. May have this patient, sepsis 80/50, and the heart rate is 132, temperature of 104. What can you do in the meantime for your patient? The patient just come in and, you know, you're with the patient. What are you going to do for your patient? Because you don't want to say that, you don't want the patient to say, you know, so the nurse over there is so idle though. You know, what can you do for your patient in the meantime as a part of your plan, or what you're anticipating from the doctor? Fluids and cooling measures. Okay, nice. Okay, anything else? Hi, good night. So, St. Elizabeth. Okay, I'm from Manchester. Okay, so you're going to be doing your fluids and cooling measures. Okay, so you have your fluids, vital signs, yes. Okay. What about your IVs? Are you planning on getting any IVs for the fluids? Sounds simple, not true. All right. Are you thinking about doing any cultures on this patient? Any blood cultures for this patient? Yes, definitely IVs. Are you going to be getting 1, 2, 3, or 4 IVs? What's the ideal you're planning on getting? Okay, you're going to get blood tests. What are some blood tests that are going to be very, very important for your sepsis patient? So normal saline, definitely. Yes, cultures and antibiotics, definitely. Okay. White blood cell counts, definitely. Okay. What about lactic acid? What if you see the doctor put in the order? Definitely, Shane. I was about to ask that. All right, but what if the doctor put in the order and the doctor didn't put any lactic acid there? Would you be like, you know, hey, you know, let me just ignore that? Or would I be like, okay, let me find out from the doctor, do I need that? Or what's the importance of you getting your lactic acid? Why you want to get a lactic acid on a patient? The blood pressure is just 80/50 and the heart rate is, you will ask for it, definitely, definitely. But why would you ask for it? Why are you so important? You know, like, why is the lactic acid important to you? Hypoperfusion, definitely. So definitely go ahead and make sure you ask about, you know, your lactic acid, you get your blood cultures, and then from there. A lot of times, you know, the doctors will put in the orders, and sometimes they might not, because not all the time it comes as a part of their, you know, their standing order. So if you see it missing, advocate for your patient and just go ask for it. If it means that you have to just pull it in the meantime, pull it, and then whenever they come, you can say, hey doc, you know, remember you never put in the lactic acid, but it's a standard, you know, a part of the plan of care for the patient. So always get your blood cultures, your lactic acid, start your fluids, you know. If it's a patient that is a COPD, not a COPD, heart failure patient. So for example, the patient has heart failure and the patient has, you know, swelling in the legs, the ankles, but the blood pressure is like 80/50, and you do the blood pressure again and you realize it is 70/40. You know, the blood pressure is tanking. What can you do? Will you be giving that patient any fluid? Would you give that patient any fluid any at all? Or you just, you know, just look at it and just kind of... Would you be concerned about the blood pressure and, like, you know, would you be giving any fluid to that patient? Yes, you'll give a small amount of fluid, and then from there, you know, hopefully the blood pressure will go back up. But, you know, in preparation, you're thinking about getting your vasopressors, getting medications that are going to be very strong for your blood pressure to get it up. But you'll go ahead and still give a little fluids to help, because sometimes even 100 mils, it might sound small, but sometimes 100 mils, 250 mils will still do, you know, justice for the blood pressure. All right, we can always go ahead and get back that fluid off, but you still want to make sure that you get the blood pressure back up. All right, so you already get your labs, you get your cultures, you get your, would you put in a catheter on this patient? Would you put in a urethral catheter on this patient? Or would you tell the patient that every time they need to pee, just let me know and me give you a bedpan? Hi, welcome. How are you doing? Would you put in a catheter on this patient? Even though we know that the catheter is a risk for, you know, infection, would you put a catheter on this patient? I'm practicing in the States here, but I got my base. I was a nurse in Jamaica for 4 years, and then I got over here. So for this patient, definitely, you know, you put in a catheter. Yes, intake and output is very important, all right, for this patient. So you want to make sure you're monitoring your patient appropriately. So you want to give an account for every drop of fluids that you're putting in, all right? You want to be able to monitor that output, all right? So definitely get your catheter in. Even if the doctor doesn't put an order for it, you know that it is important. That is one way for you to actually monitor your output. So definitely advocate and ask your doctor to put the order in for the catheter. All right. And not only that, especially depending on the age of the patient, at least you'll be able to get your sterile urine. All right. So if you have a patient that is sepsis, you know, the blood pressure is low, especially your elderly patients, you want to make sure that they don't have any UTI that is causing them to have, you know, the hypertension. So that is one way to get a sterile urine. So if you see a patient coming in looking like this, you just get everything going, you know, start your catheter, get your IVs, get your cultures, and then from there. What if you're doing your blood and you can't get the cultures? You can't get enough blood for your cultures, and the doctor put in the order for the antibiotics. Will you go ahead and give the antibiotics, or you'll just wait until, you know, you can get the blood culture? So you're there struggling for the last 15-20 minutes. You get the IV, but you can't get any blood from this patient because the patient is just too dry. You know, the patient don't have enough blood to give you to say, okay, then this is the amount of blood I need for my culture, so take it. You know, will you go ahead and give your antibiotic, or will you wait until you get your blood cultures? You know that cultures first, but even, so for example, you're there and it's 30 minutes. 30 minutes, you're trying and you stick the patient, you know, 5 times. Another nurse come and stick the patient and you can't get the blood. What are you going to be doing? But you still have the IV, but you know, you have the IV there, and you still just cannot get the blood. Give the antibiotics. That's more important, definitely. So if you're there and you're struggling with getting your blood cultures, just go ahead and give your antibiotic, because that is what the patient needs. We definitely need the blood cultures, you know, before giving the antibiotic. But if you're struggling with getting the blood cultures, go ahead and give the patient the medication, because that's what the patient needs to get the, you know, the infection down. All right, so administer your antibiotics to get your infection, you know, the bacteria count going down. Eventually, you can get your blood cultures. Just mark on it. I normally write on the bottles that vancomycin was given before, or, you know, cefepime was given before. So that way, at least they'll know that before, you know, this blood is actually, like, you know, contaminated with the vancomycin or the antibiotic. All right, so we can at least have an idea. But definitely the organisms will be there, definitely Lily. So go ahead and just start your antibiotic, because that is important for the patient right now. So Shayna is saying, what books you study from? I've been a nurse for a long time, but you've been feeling inadequate. So you know that I am always using so you know the pathophysiology book, that was always my best friend. So I have a pathophysiology book that I always use. I do use a lot of YT videos, YouTube videos, to help with explaining certain things, and I think with experience as well. But the pathophysiology book and the management, I always try to make sure, you know, those are things that I get, because I always feel as though once you're able to do that, you know, you can produce, you can give the best care, and that's just it for me. So yeah. So I always just use those information to help with answering. So that's why I always tell people, make sure you're reading broadly, and make sure you're reading broadly, study broadly, understand the pathophysiology. Once you understand the pathophysiology, and I'm not like 100% when it comes down to pathophysiology, you understand, but I try to make sure I understand as much as possible, because that is going to help with me managing my patient. Yes, so I was trained in Jamaica, and then I did my master's here for my NP. All right, so definitely go ahead and do that. All right, in terms of that sepsis patient. The client who has stable angina, who requests nitroglycerin, as I say, that one, I understand A to Z, but freezing an emergency. Any tips? I don't really know when it comes on to the emergency. I guess because my background is in emergency. I don't know if, what area are you in? I just always, like from, from as I was in nursing school, emergency room was always my thing. And so, I don't know. I'm always just like curious. I'm always just wanting to help. So when it comes on to the freezing part, like, I don't really know how to help you with that part. Because, it happens every now and again. Because sometimes you might have a patient that comes in and it's the first time you're seeing the case. And sometimes it's like you go blank. You understand? But I always try to just use my ABCs, airway, breathing, circulation, and try to find out what is it that is important. And as I say, I'm always the kind of person that is using differential. You'll hear me talk about differential diagnosis even before being a nurse practitioner. That is just how I'm always thinking, because that's how I was trained. You're always thinking about all different things that are happening. And then from there, if you can come up with your differential diagnosis, and if you're able to say, okay, then this is the one that's going to kill the patient. This is the reason why the patient is going to die. And if you can jump to addressing that one. And if in your, if you keep that mindset that all the time, the patient that is in front of you, this is what is going on, I need to address this one first. It kind of helps with relaxing you a little bit and helping you in those emergency situations. At least that's how I look at it. So, yeah. So kindly share with us some of the YouTube channels and resources you have been using. So you know that I know a lot of persons talk about the RN, registered nurse. I've never really used her when I was studying. I never really used her page, but I'm more of a visual learner. So when it comes on to like videos, you have a lot of channels that you'll have like anatomy and physiology. And I always look at the reviews, and I also look at who is teaching, like, if it's a doctor, nurse practitioner, but most of the time they are doctors. And once I have my textbook and I'm looking and it makes sense, I just need to have an idea. I don't really know the exact YouTube channels that I would say, but you have a lot of like anatomy and physiology channels out there that you can look at. It's been a while now, so honestly, yeah, but just go on and find the different channels out there that are credible. All right, you have a few of them out there, so just look them up, and then from there you'll see the names. Not a problem, Renorta. Thank you so much for tuning in. Oh boy, what I start. You're good. Armanda draws while teaching, and it's very helpful. Okay, I guess I don't know about that one, but you can go ahead and put it there for persons who are interested, Lily, and then from there. All right. So, and then we said that the client with the kidney stones reporting the flank pain is also one that definitely will be addressed. So for that patient, you also want to go ahead and make sure the patient is getting a large amount of fluids to help with getting some of that stones out. All right. And then you talk about your pain medications and all. All right. So definitely look at that. Oh, I think we did that one already. And we did that one. Okay. So what time is it? 9:18. All right, so a client, which client requires immediate intervention? So these are 4 post-op patients you have. Which one requires immediate intervention? Is it the post-op client with urine output 20 mils per hour? Is it the post-op client with pain 8 out of 10 at the incision site? A post-op client with hypoactive bowel sounds? Or the post-op client with a mild serosanguinous drainage? Who will you be going to see first in terms of your post-op patient? So you're on the floor. This is a post-op floor, and you have these patients. Who will you be going to see?
There's a fly.
You need to go to your bed. Okay, the post-op client with the urine output. What urine output are you anticipating for this patient? So luminous. Is this luminous that is on TT? At least 30 mils per hour. Definitely, Shayna. So you want at least 30 mils per hour in terms of the urine output. Okay, luminous. Okay. All right. So the pain at the incision site, you know, you're expecting for them to be having pain because they just recently had surgery. So they're going to be having pain. So pain management is something that you want to be, you know, on top of. The hypoactive bowel sounds, their bowel sounds are going to be hypoactive at the initial phase. So you continue, you know, monitoring them, listen to their bowel sounds to make sure that you're having return of their bowel sounds. All right. Because remember, you're just getting them from the operating room. So, you know, their bowel sounds are going to be poor. And the post-op client with mild serosanguinous drainage, it's mild. All right, so you continue monitoring. You don't want it to be too, you know, too bright red or too much, you know, that you're getting from the drainage because, you know, that patient is going to be at risk for hemorrhage. So you want to make sure you monitor the patient and it stays at mild and not, you know, severe. All right, in terms of the drainage. So the urine output is the one that is concerning because it might indicate that, you know, the patient is having poor perfusion. So you want to go ahead and address that. So you want to start off with getting your fluids. All right, get those fluids going so you can actually have, you know, better output for the patient and prevent any shock from happening. All right. All right, so it is 9:20. It's 9:20. I am going to, I probably should have said this before. I'm going to do about 5 more questions and then that is where we will end our live for today. I didn't realize it was this late. All right. So which client is priority? Which client is priority here? A client with thyroid storm with a heart rate of 160. A client with Addison's disease reporting fatigue. A client with Cushing's disease with weight gain. Or the client with hypothyroidism with cold intolerance. So which of the patient here is priority? So the thyroid storm with heart rate of 160, the client with Addison's disease reporting fatigue, the Cushing's disease with weight gain, or the hypothyroidism with cold intolerance. So I am on, I do the live and on Tuesdays and Thursdays at 7 p.m. All right, I go a little bit longer on Thursdays because most of the time I am not working on a Friday. So definitely A, yes. So the thyroid storm with a heart rate of 160. What are you concerned about with this patient with the thyroid storm? So the patient has a heart rate of 160. The patient has thyroid storm. So risk for arrhythmias, all right? It's always going to be something that is concerning. All right, the Addison's disease reporting fatigue. Definitely you'll address that patient. Cushing's disease with weight gain, hypothyroidism with cold intolerance. Those are okay. All right. You have four clients. Who should you see first? The client with septic shock of 80 over 40 blood pressure, a CHFL with who is orthopnic. You have a COPD with a chronic cough, or the diabetes, that patient that is reporting thirst and polyuria. Who will you see first? Is it A, septic shock with a blood pressure 82 over 40, CHFO with orthopnea, COPD with chronic cough, or the diabetes patient with thirst and polyuria that they're reporting? A, septic shock. Yes, you'll definitely do the septic shock for this patient. CHFO with the orthopnea is pretty common, you know, a lot of times because they have the fluid, you know, the excess fluid. A lot of times, you know, depending on the position, you know, they tend to have that issue going on. The COPD with the chronic cough often tend to have the, you know, the chronic cough as well. And where does fly come from? And then the diabetes patient that is reporting thirst and polyuria, pretty common for your diabetes patient. All right, well, the septic shock is one that is having the hypotension and is at risk for, you know, perfusion problem, inadequate perfusion. So you want to go ahead and address that patient immediately. All right. All right. So you have these four patients. Who should you see first? Is it the patient with Guillain-Barré reporting shortness of breath? Is it the patient with multiple sclerosis with muscle weakness? The client with Parkinson's disease with a slow movement? Is it the client with Alzheimer's disease with memory loss? So who will you go and see first? Is it the Guillain-Barré patient reporting the shortness of breath? The multiple sclerosis with the muscle weakness? The Parkinson's disease with slow movement, Alzheimer's disease with memory loss? Who will you go and see first? A. Definitely. And sometimes, as I say, if you don't know that, you know, if you don't know anything about the condition, if they do give you like the signs and symptoms, then always look at the one that is like, you know, life-threatening, or still use your airway, breathing, circulation to answer. So the Guillain-Barré reporting shortness of breath is the one that is correct, because they're at risk for respiratory failure there. Your multiple sclerosis, they definitely have the muscle weakness. So, you know, Parkinson's disease, slow movement is a, you know, a symptoms or a sign for that patient. And the Alzheimer's, it's pretty common for them to have the memory loss. All right. So the one that you're concerned about is the one that is reporting the shortness of breath. All right. Which client is priority here? The client with stroke with expressive aphasia, the client with stroke with new unilateral facial droop, the client with stroke with epiparesis improving, or the client with stroke with mild dysphagia. So you have the four patients. All of them are stroke patients because you're working on the stroke floor. Which patient is priority? The client with stroke with expressive aphasia, the client with stroke with new unilateral facial droop, the client with stroke with epiparesis that is improving, or the client with stroke with new mild dysphagia. So we have BB, okay. BB, okay. So yes, so the patient that has a stroke with new unilateral facial droop, what does that mean? The patient is having another stroke, no? So yes, your car. No, so it's gonna be A, the one that has the new unilateral facial droop. More than likely, the patient is having another stroke. All right. So you want to go ahead and address that patient. The stroke with the expressive aphasia that is existing, you know, you definitely will eventually go and evaluate to see, all right, if there is anything that is worsening. The epiparesis that is improving, patient is doing well. The stroke with mild dysphagia, a lot of times, you know, you have your patients with stroke, they have the dysphagia as a part of their, you know, their symptoms or their signs. So definitely you want to go ahead and, you know, monitor that patient. But the one that is priority here is the fact that he or she has new unilateral. So new one side of them face start drooping, you know, is weaker than the other. So you always want to go ahead and look at that. It can be that the stroke is worsening or they're just having a new stroke on the other side. You understand? So just look at that. All right. And that will be it for... Oh, one last one. The last question on the paper or on the computer. Which client should be seen first? A client with nephrotic syndrome with facial edema, a client with acute kidney injury with potassium of 7.0, the client with chronic kidney disease with anemia, or the client with kidney stones reporting flank pain. So which client should be seen first? You have a patient that is having nephrotic syndrome with facial edema, the client with acute kidney injury with potassium of 7, the client with chronic kidney disease with anemia, and the client with kidney stones reporting flank pain. So who will you go see first? High potassium. Definitely always go for your high potassium. Your nephrotic syndrome, what is something that is very common? So you have the facial edema. With the nephrotic syndrome, sometimes they tend to have dark color urine as well. What are some of the signs and symptoms for patient with nephrotic syndrome? See? No, so it's actually the one with the potassium. The swelling, yes. So they tend to have the swelling in the face, the legs. Okay, what else can you tell me about nephrotic syndrome? They have the proteinuria. All right. All right, let me pull this up. So they have the proteinuria, excessive protein in the urine. They have the edema, the swelling, especially in the face, the legs, and the abdomen. Hypoalbuminemia. God. Low protein levels in the blood. All right. Fatigue, increased risk of blood clots, and they have high cholesterol and triglyceride levels. All right. So they're very, very known to have the swelling in the face. All right. And a lot of times they tend to start having, like, you know, their urine tends to become dark because their kidneys are failing. So you want to look at those patients very carefully. Your acute kidney injury patient, potassium 7.5, you want to address that one because it's lethal. All right, with the potassium. So you want to look at, you know, your arrhythmias. So you do everything to help with preventing the patient from getting into any cardiac arrest because of that potassium level. Your chronic kidney disease with anemia, a lot of times they tend to become anemic, all right, because of the kidneys. Yes, elevated glomerular filtration, good. And then the kidney stones, reporting flank pain. So a lot of times, you know, when they're having the flank pain, they have the kidney stones there. So I want to try and get rid of that, you know, the kidney stones there to help with their pain. And once you start them on high fluids, high amount of fluids, like, you know, that will help us a lot with getting that, you know, stone to be flushed through the urethra or, you know, the ureter. You understand? No? A lot of times, depending on the size of the stone. So you always want to make sure you're giving those patients large amount of fluids. All right, help with getting those stones pushed down. All right, and then from there, so the severe hyperkalemia is the one that is most concerning for these patients. And then you can always decide who you'll go and see for the others. All right. And that's about it on those questions. Sorry, close that door for me. All right. And that's it for those questions. Do we have any questions, concerns? Where did this fly come from? No, sir. Oh, yes, I do play a little game every now and again. Yes, I do play a little game every now and again. But it can be very addictive though, you know. One really. Yeah, it can be very addictive. Yeah, you'll sit down and play a game for the entire day. All right. All right, but yeah, so I want to thank you guys for showing up and being so interactive on the on the live here. You know, with the questions and everything. Do definitely show up again next week. Today's what? Thursday. Yeah, next week Thursday and next week Tuesday for more questions. And I still do show up on the live at 7 throughout the week as well. You know, 7:30, and just be hanging out answering questions. If you have questions regarding, you know, nursing or you know, being an international nurse, things like those, I definitely talk a lot about that. So you can always come and ask question, how I got to the States, things like that. You understand? And you can also go ahead and subscribe to my YouTube page at ThinkNursing. The full length of the live sessions are always posted over there. So you can always check those out, and a bag of things over YouTube. So definitely go over to YouTube and look at that. Jamaica time, yes, for now. All right, for now, because I don't know, I don't even know when the time change. Whenever the clock change, you know, then the time is gonna be 1 hour ahead. But Jamaica time, next week until, you know, I figure out what time it's gonna be later on in the year. But it's gonna be 7 o'clock at that time. Hi Kumar, welcome. So I will be here. So yeah. All right. So make sure you go over to the YouTube page and subscribe. And as I say, the live streams, they do have a lot of information. There are questions that I've already done on previous live stream, just in case you missed them. You can always play. Where does fire come from, dear Father? No, sir. Sorry. I'm so big. But I will definitely, you can definitely go over there and look at those, and then from there. All right. And as I say, I talk about my transition experience with a recruiting company, how I got to the States, all of those over there. And just extra things, you know, that is not related to nursing, that you can, you know, just have fun watching. I talk about my journey growing up, you know, where I'm coming from, and, you know, all of those things I do share on my page. So, and if you're a nurse and you want to be a part of the podcast, then, you know, come and share your story. It's more of a motivational page. It's supposed to be like a motivational page where you come and share your story, a day in the life of a nurse, things like those. I want to do a foundation. I want to give back to communities. So yeah, I want to do traveling to different places, interview nurses, not even really interview, but, you know, just talk. I want to have conversations, real conversations with people. What study materials do you recommend for NCLEX? Oh Lord. As I said, just make sure you study broadly. Make sure you're reading your pathophysiology book. Make sure you're reading on your pathophysiology, your pharmacology. And I guess you can do the, you know, the question, the test questions, but don't rely solely on review courses, because as I say, I tell you what I can remember, but it doesn't mean that whatever I share with you is the only answer that is out there. All right. Go understand the pathophysiology and the different rationales, you know, for different things out there. And then from there, at least that will help you with answering your question. All right. Because when you do look at like review courses, it just makes you a little bit narrow-minded. And you just feel as though when you go there, this is the only way to answer a question, or this is the only way to manage the patient. So that's why I say I didn't really use like review courses or anything like that. I just study from my pathophysiology book. I'll still use 1 and 2 questions, but I never really rely solely on one specific text. All right, so that's all I can say on that. You're welcome, sweet Tima. So my YouTube name is ThinkNursing. It's the same name as my handle here on TikTok. All right, so definitely go over and look at that and subscribe. Fly telling you to go. I'm if it tell you, the fly knows someone wants to see for a long time. Fly know that. So I take my NCLEX in December and I'm using Remar. Okay, so someone on YT here is using Remar, R-E-M-A-R. So you can also look at that. All right, you can also look at that. It's fully content. You can't answer questions if you don't know the content. Definitely, yes. You have to know the content in order to answer the questions. The many faces of Nicole is saying on YT here. What is the pathophysiology books you have always talked about? So my pathophysiology book was, all right, so I don't know if you know this big red read med-surg book. That's the one I got in nursing school. And my pathophysiology book now, well, this is the one that I purchased for my NP because I never brought that one from Jamaica with me because I gave it to somebody else. But it was always my resource. But I use the advanced pathophysiology now. But for your NCLEX, I don't think you need to be using the advanced pathophysiology. You can use the same one from nursing school. All right, you use the same one from nursing school. That's the one I was using. And I also use some questions from chat GPT for questions, and make sure I use in my book the internet, you understand, to look up and make sure that chat is giving me the right thing, you understand, because not everything on chat probably is correct. I don't know, so don't trust chat 100%. Use different resources to help with your exam. All right, I know they always talk about UWorld, so you can use the test bank for UWorld. What else? Yeah, that's it. And just know your medication. So when did you take your NCLEX? I took my NCLEX in 2000 and so I came to the US in 2016. I took my NCLEX in 2000 and oh, I have it in my phone. Let's see. I think it was like 2015. I think it was probably 2015. I have everything in my phone. So nursing, so I have them listed as like nursing credentials, my credentials, nursing license and expiration dates, taxi schedule. That's how my phone is set up. Monthly expenses, my NP package request, whatever I'm requesting for. Yeah. Use up your notes section of your phone. All right. So what you're asking for again? Nursing license. So see, I'm not lying. My nursing license and expiration date. That's how I keep track. So all my certifications, I'll put them there with my license number, expiration date, whenever I did my NCLEX or whenever. So my NCLEX date was October 27, 2015. That's when I did my NCLEX. My graduation date from nursing school was August 14th, 2011. All right, and I did my RENR, my regional exam in Jamaica on October 5th to the 6th, 2011. And my nursing license in Jamaica expired on December 31st, 2017. So I have everything, like I save everything. Yeah, I like organization. I do the same notes. In notes, I have all my licenses. Yeah, definitely YouTube is a great resource. The shorts help me. Good. And Quizlet. Oh yes, Quizlet. I totally forgot about Quizlet. I did use Quizlet as well. I didn't do a subscription to it, but in terms of their flashcards, they had a lot of questions there. So totally forgot about Quizlet. So that is one thing I definitely used a lot in nursing school. Quizlet. All right. 2015, I was still at high school. Okay. So definitely look up those and use it. I totally forget about Quizlet. Quizlet was really good though. They have a lot of information on Quizlet. Yeah, and I've realized that even when I was doing, I don't remember which course I was doing here in the States. I think it was the CEN, the Emergency Nursing Program, and I realized a lot of questions came from Quizlet. So Quizlet seemed to be a trusted source for even the CEN program here in the States for the exam. You understand? So definitely use up CEN, not CEN, the Quizlet. Quizlet is not an app. You can go online and just type in Quizlet questions and you'll find different answers popping up. All right, for whatever it is that you want to do, you'll find it popping up. But as I say, you have to know you have to know the content. You understand? You have to know the content still to answer the questions. You can always use the review courses at the end. You know, once you feel as though you're ready to test, you go ahead and use your resource courses to help with, helping with you preparing for that exam. But I think if you're starting out studying, I think right now you need to be reading from your textbook, your internet resources. but not from too much, because you have some people who study from multiple content books and confuse themselves. You understand? Confuse themselves, and when they go in the exam, them just overload with information. You understand? I remember I was doing the emergency program in Jamaica, and there was this young lady in class, you know, let me tell you, the girl she sounds smart, but she always a fail her exam. She always a fail the exam, and she and the teacher always just having, you know, argument over the course, because she get information from so many books, and some of them are not even evidence-based. You understand? And when she get into the class and do the exam, she write down a ton of information, and she always getting it incorrect. So I say, don't try to study from 10 different books. You understand? You just want to get a good knowledge of the content. So if you have 2 books, 3 books working with, it's good enough. You understand? So find your trusted sources. Try and find, you know, the ones that are evidence-based, and you work with it. And once you get that concrete information, you're good to go. You understand? You're good to go. And then you can always use your YouTube videos to help with, you know, the pathophysiology itself, because that is the most important thing. All right. And then from there. All right. Well, Full Sexy Lips 27. Welcome, welcome, welcome. How are you doing? Aaron Tantan. Yeah, so basically that's about it, you know. That's about it. I have I'm not working tomorrow, but I am going to sleep. Renorta. Yeah, I'm going to sleep because I think I've been running short on that for a couple months now. I'm going to try to see if I can get up at 3 o'clock and start some notes, because I have some things I want to do tomorrow. So I don't want to spend my day tomorrow, Friday, completing notes. And I don't want to bring any notes into the weekend. So that's what I'm going to be doing. So I'm going to get up at 3 o'clock, do my notes, probably ride my bicycle for 10 minutes. Yeah. And you can join me at 5:30 in the mornings for my spin class. All right. So try to ride my bicycle to spin off. I try to ride my bicycle in the morning to cut down some of this belly fat. You know, this belly fat thing that we complain about as women. Yeah, man. So it's more for health. Yeah, that's what I'm doing my classes for, to stay healthy and fit. But eventually, you know, you need the waistline cut down too. All right, but anyways, I'm doing that in 5:30 in the morning, so I stream it just to have company, because me like company. So just like how you guys love company, that's me. I love company when I was doing my nursing program, but not all the time, because, you know, sometimes when you're just learning the content, I have to stay by myself and study. And then once I feel as though I understand it, then I'll get into the group. So I have to always be reading ahead, and then I'll go into the groups afterwards. So that was just me. But I like company when I'm exercising, because it kind of keeps me motivated. It's 3 a.m. in Ghana already. 3 a.m. Oh. So tomorrow morning, that is what? So 3 a.m. So yeah, that's like, anyways, me can't do the maths on that one right now. One really can't do the maths on that. What is it? What time is it gonna be? Like, you know, 5:30 tomorrow morning. That's gonna be probably around 5 in the evening or so. So thank you, Christine. Thank you, thank you. And remember, guys, go ahead and, you know, follow me, and I'll follow you back. Once you have a name and a face, I will follow you. All right. Just as sometimes TikTok will say that you're following too many persons too fast, so you can't really follow everybody, you know. So all right, well, I am gonna go, and then I will see you guys in another live. And just come out on at 7 o'clock in the week, all right, and we'll hang out and chit chat. All right, but I want to say thank you guys for tuning in, and it was nice having you guys here. All right. All right, then. Enjoy your evening here on YT.